sponsor, no commercial intent. These are pure educational, independent, scientifically independent educational exercise. I'm very impressed to see how many people are connected. I wish to thank Mariam and Alisher for having put all the effort in putting together the connection and the technical connection. And I wish you all the best. And I really ask you to give us feedback on how we could improve and make more effort from the European School of Oncology and the European School of Oncology College to support your generation, which is the next generation in oncology. Have a nice day.
Thank you so much.
Thank you.
Excellencies, distinguished delegates, dear colleagues, ladies and gentlemen, I am deeply honored and privileged to welcome you all to the first international webinar on gynecooncology supported by ESCO members. The novel coronavirus pandemic forced us to an unusual new step. This time we were online, but it will not be a break for us at all. Vice versa, actually we will find our new place in the sun. The people who made this webinar are national born leaders. It means that we will see all possibilities and opportunities in any crisis. And as a result of it, today we will make new stylish webinar full of fruitful, solid and impressive scientific discussions. First of all, I want to present Professor Alberto Costa, CEO of European School of Oncology, founder of European School of Oncology. He has authored over 250 scientific publications, and he is the recipient for several hours. But today, I want to present him differently. He is a person who provides me with the right tools, guidance, and feedback. And it is too important for me to thrive in my career. I am very grateful to him for insights and context he provides me with constantly. And I want to add that he among those rare persons who has a genuine joy to help other people. Thank you, Professor Costa. Next, I want to present Professor Jan Vermorken, Emeritus Professor of Oncology, Antwerp University Hospital, Belgium. Frankly speaking, I have feeling that meeting and knowing him, it's the greatest even gift for me in my life. I am very thankful to him for all strong words of support, for all opportunities that allowed me to have new and first step in European School of Oncology and European Oncology, publishing house to establish new international contacts. It should be mentioned that he is equally sane as well, equally friendly, warm-hearted, and supportive. Dear Jan, you are a living legend, and all your achievements are priceless. Thank you so much. Next, I want to present most respected, dignified, and honorable Madame Cristiana Sessa, Professor of Oncology, Oncology Institute of Southern Switzerland, Bellinzona. Professor Sessa, we are very thankful that you are sharing your time with us, your experience and your knowledge. We really appreciate it. Thank you so much. We represent Avex Medical Corporation, the largest chain of hospitals in Georgia. We are doctors from 2 hospitals, and our audience consists of clinical oncologists, radiation oncologists, surgeons, and pathologists. My name is Mariam Kukalashvili, and I am clinical oncologist, and I am a winner of ESCO Mentorship Program 2021, and it's my great honor to be Alberto Costa's mentee. You know that Georgia is very famous for its hospitality, and now I want to invite my friend, Professor of University, Shorina Barbakadze, who will make very small virtual tour around Georgia country in which you are invited. Please, Shorena.
I want to say that I would like to express my sincere gratitude to Dr. Mariam Kukhalashvili for inviting me to the conference and also for giving me opportunity to say a few words about our precious country. And I do hope you will accept our joint invitation about visiting Georgia. So first of all, and then I want to share a kind of PowerPoint presentation with you. Yeah, okay. So, Mariam asked me to talk about the following issue, who we are. So, as she already mentioned, I'm Shorena Barbakadze, Associate Professor at Tsereteli State University and Founder and General Manager at International Language House. I'm neither doctor nor a representative of medical sphere. I'm just a friend of doctors. And I try to give you a quick view about our country, Georgia. Yeah, you see,
can you share your screen, please?
I'm sharing it.
It says that it's coming, but I don't see yet. There may be some slow problem with the internet.
Alistair will help us.
Yeah. By the way, we are scared of the managers, so.
Alicia, if you allow me, I can share my screen for her, please.
Yeah, because I'm sharing it. Okay, maybe I will pause it. I don't know what's wrong with it.
No problem, Shorena, I will do it.
Okay, then I will pause it for you.
Wait a moment.
Yes. Please stop sharing your screen and I will do it.
Yeah, I have already. Yeah, most of the world that calls our country Georgia, just like one of the states in USA. So sometimes people are confused. However, we locals call ourselves Kartveli and our country Sakartvelo. So the question is, what makes Georgia unique? The answer is simple, it's a location. So Georgia is an important trade and logistics hub. Energy goods from Caspian Sea to Europe are transited through Georgia. So this country is a very important point on the world's political map. Due to the location, Georgia is blessed with climate that produces some of the best fruits and vegetables in Europe. The climate is also very friendly to winemaking. Breathtaking nature makes Georgia an advised touristic destination, sunbathing, skiing, hiking, river safari. It's all possible on this tiny plot of land. Georgian people and culture have been impacted by Asian as well as European culture. This is a quite exotic mix worth experience. It's located on an important trade route from Asia to Europe. You can easily travel to Georgia from almost anywhere in the world. Georgia is a very safe and secure country, and there are literally no banned places in Tbilisi as well as the rest of the country, except for Samachablo, so-called South Ossetia and Abkhazia, that are occupied by Russian Federation. So conflict with Russia is a long-lasting struggle, most consequent to Georgia's Western-oriented choice. Majority of the young population is fluent with English, especially in the urban location. Democratic values are thriving among locals. However, centuries of Asian as well as Russian influence is common. You see, every platform should be used, even ours, to raise a voice against Russia and its continuing occupation of Georgia. And as you can see on the screen, 20% of Georgia is occupied by Russia. Plus, I want you to know some significant things about the city of Kutaisi, which is the second largest city of Georgia, not only after the capital Tbilisi. However, its history goes back to ancient times, where legends and reality get mixed. Kutaisi, capital of Colchis, was the land where Iason and the Argonauts arrived in their search for the legendary Golden Fleece. And the medicine as a discipline itself owes a lot to Kutaisi, and that's why I'm accenting on it very much. According to mythical heritage, you may know Medea, a daughter of the king of Colchis, famous for her beauty, was very wise and closely associated with plant lore, cantation of medicine, and medical activity. She knew various forms of remedies for internal and external use, respiratory, and so forth. In her therapeutic arsenal, there were medical remedies for a variety of uses for treatment of various diseases, soporifics, poisons, ointments, miraculous, and magical substances as well. Medea prepared the poisons by using special processing of medical remedies, extraction, infusion, tincture, thermal, mechanical, or chemical exposure, or concentration. The principle according to which the modern medicine is developing is contraria contraris curantur, C, or contraries are cured, or allopathic medicine. At present, the priority still belongs to CCC. This is the direction that modern medicine and pharmacy throughout the world are following today. If we go through the text of the Argonaut story, it says that she used to wander at night in the copses near the temple looking for plants for treatments. The amazing medical miracles attributed to Medea by Apollonius of Rhodos, the author of the Argonautica, while allegorical, are undoubtedly based on reality. Medea was skilled in the quick and effective treatment of wounds. Medea healed with special herbs and roots in a few days. She was able to treat sterility as well. She told the king of Athens that his sterility would be at an end. Still, you don't know by what chance you came to me. I know the medicine against sterility. She was familiar with cosmetics as well. The discovery of hair coloring is attributed to her, as are the secrets of skincare. Medea rubbed and healed her skin irritated due to clogged tears. With the sweet nectar oil in her medical practice, the woman healer practiced blood transfusion, as well as using a lamb as a donor. This procedure was carried out on Peleus, Jason's uncle. The story is quoted from academician Kasirsky. Medea took her unsheathed knife and cut the old man's throat, letting her all of his blood out of him. She filled his ancient veins with a rich elixir, received through his lips and wound. His burden hair, no longer white with age, turned quickly to their natural vigor, dark and lustrous. His wasted form, renewed, appeared in all the vigor of bright youth. The way of effective realization of this principle is a strong chemical source. The stronger the source, the more effective the result. Thus, Medea is not only considered a pioneer of cosmetics, hematology, surgery, toxicology, and other areas, but also the founder of the way for effective implementation of the main principle of modern medicine and the donor of word root medicine. Afterwards, the term acquired a broader generalization and consequently became a synonym of medical art. Now a few words about Kutaisi. So it's located in the Imereti region on the banks of the river Rioni. As you can see, I have some photos there. Kutaisi is the administrative center of Imereti region. It's one of the oldest cities in Georgia and fifth among the oldest cities in Europe. The city has been inhabited since ancient times. The existence of Colchian culture is confirmed here from 15th, 18th centuries BC. Documentary history of Kutaisi dates back to the 3rd century BC. Though ancient authors considered it the capital of the kingdom of Colchis, the old names of the city are Aya, Kotaia, Kotatuisi, and so forth. Here, David the Builder was blessed. David the Builder built the Galati Cathedral near Kutaisi, which became one of the most important educational centers of Georgia. Kutaisi has maintained the status of a united Georgian capital for 124 years. In 1122, David the Builder moved the royal throne in Tbilisi. However, Kutaisi remained an important city in the cultural and historical significance. Nowadays, Kutaisi is the second city of Georgia with its developed infrastructure and culture. There are higher and professional colleges, museums, theaters, galleries. So Kutaisi attracts many tourists with its abundance of historical and cultural monuments. The castle of Vikimerioni, Galati Bagrati Cathedral, as well as many other cultural and natural monuments, and the beauty of the city itself will surely make you feel in love with Kutaisi. Now, the question is what to see in depth. So, Kutaisi and its surrounding areas are distinguished by the beautiful nature, as you can see from the picture, and abundance of cultural monuments. If you visit Kutaisi, you should definitely visit Sataplia and Prometheus caves near Kutaisi, Zaldogo municipality. There are many beautiful karst caves in Imereti, in addition to the magic halls adorned with stalactites and stalagmites in Sataplia. You will also be able to see dinosaur footprints and travel through the prehistoric world. Ogatse Canyon in the municipality of Hon is also beautiful with the hanging path, waterfalls, and amazing views. There is also a Gabzarvili Lake, Cracked Lake in English, it's called like, and waterfall deep in the rocks near Kutaisi. One of the sites of the city is the Kutaisi Botanical Garden, where about 700 species of plants are cultivated. So the history, Tbilisi. Now let's move about, say a few words about Tbilisi. I want to keep my time. Tbilisi is Georgia's ancient and vibrant capital. City spreads out on both banks of the Kwari River and is surrounded on 3 sides by mountains. The most widely accepted variant of the legend of Tbilisi's founding says that in the mid-5th century, AD, King Vakhtang Gorkasali was hunting in the heavily wooded region with a falcon. The king's falcon allegedly caught or injured the pheasant during the hunt, after which both birds fell into a nearby hot spring and died from burns. King became so impressed with the hot springs that he decided to cut down the forest and build a city. The name Tbilisi derives from the Old Georgian word tabili, meaning warm. Archaeological studies of the region indicate human settlement in the area early, as the 4th millennium BC. The main sites of the city are clustered in the Old Tbilisi district, as you can see from pictures, and this area is well known for its bathhouses fed by natural hot springs. Nearby on Shardani Street, you will find plenty of modern, popular restaurants, trendy nightclubs, and art galleries, and so on and so forth. So as for Batumi, we should say a few words about Batumi as well. So it's a very important city for us, a Black Sea resort and port city. It's the capital of the Georgian Republic of Ajara. Batumi Boulevard encompasses a waterfront promenade with a park and a beach, and the 130-meter high alphabetic tower adorned with Georgian script has a seaside observation deck. The old town district is lined with renovated 19th century buildings. Although industrially developed, Batumi is an attractive city and popular resort. Its many gardens and its streets are lined with exotic plants. North of the city is the Batumi Botanical Garden with a rich collection of subtropical and tropical plants. So Batumi is the center of tea and citrus growing area. There are tea plantations on the city outskirts. The Georgian alphabet described as a living culture. We'll have picture, living culture of 3 writing systems, and has been added to a UNESCO representative list of intangible cultural heritage of humanity. And Merkulovani was the first alphabet from which the Nuskuri was derived, followed by Hedruli. And also I want to draw your attention to the
Thank you, Sharena, for your
And lastly, I want to say that it will be a great honor and privilege to see all of you in Georgia. And it was just a quick view of my country, accenting on Kutaisi and its role in terms of medicine. In case of any questions, remarks, notes, and etc., I'm open to answer them. Thank you again, and now let's follow the webinar program. Thank you.
Thank you, Sharena, for your impressive presentation. Now I want to introduce Alberto Costa's second mentee, Ali Shurkakharov from Uzbekistan, and his head of department, Professor Polatova. Please.
Good afternoon, dear colleagues, professors, friends. I am honored to co-host today's webinar. We are well aware of the tremendous work done by European School of Oncology in the field of medical education. We remember the achievements of its legendary founder, Professor Umberto Veronese. It is also very gratifying to note the joint hosting to the webinar with our colleagues from sunny Georgia, the homeland of many outstanding oncologists. On behalf of the Oncomaktab School of Oncology, uh, the Tashkent State Dental Institute, the Association of Oncologists of Uzbekistan. Let me thank the European School of Oncologists represented by Dr. Alberto Costa, our distinguished Professor Vermogt and Christiana Sisa for taking the time to read the reports. Dr. Maria Kuhalashvili for the well-formed program of today's webinar. I wish all participants to make the school useful. Thank you.
Alisher, please.
Good afternoon, dear professors and colleagues. It's a great honor for me to participate in today's events. The European School of Oncology is the organization that opened the window to world of oncology for me. In addition, the project of the College of European School of Oncology and the opportunities it's present, in particular the mentorship program, which gives the opportunity to closely communicate with the leading oncologists of the world, is very interesting for us. I am very grateful for my mentor, Dr. Alberto Costa, for his helpful advice and comprehensive help. And I also let me express my gratitude to Dr. Mariam Kukashvili, Dr. Vermorgen and Dr. Christina Sesse for the time they have allocated for their reports, as well as to all the participants of our webinar. Thank you for your attention, and I hope everything will be okay for today's meeting.
Thank you, Alisher. Now let me start our webinar, and I want to give the floor to Professor Vermorken, who will talk about the ovarian cancer guideline review. Please, Professor.
So can you hear me?
Yes.
Oh, very good. So I'm going to share screen. But first of all, before I do that, I'd like to say to you, Mariam, that I'm very happy to be with you again. It is a long time that we have seen each other. And fortunately, we could keep contact by email, but it's never as good as being face-to-face to each other. And I'm very sorry that this first seminar needs to be done online. I would have liked to come and visit you. That would have been a great pleasure for me.
Yes, of course. You are invited anytime to our country. Thank you, Professor.
So I'm going to share the screen now. Let me see. Can you see it?
Yes.
So.
Please.
All right. So I was asked to talk about the guidelines recommendations. And of course, as you know, there are many guidelines, and in my hospital, we are mostly referring to NCCN guidelines, but also when it concerns gynecological oncology, we look also at the ESCO guidelines. So this is a sort of integration of that, and I'm sure that my good friend Christiana will automatically and immediately correct me when I'm not referring enough to the ESCO guidelines, because she is one of the drivers of these recommendations. So this is my conflict of interest disclosure. And I'm just, I think I will close this here and to have a full screen. So as an introduction, I don't have to tell you that, but I think it's good to have at least 2 slides for introduction. So when we talk about ovarian cancer, we must realize how dangerous this cancer is for women. It's the most lethal gynecological cancer. And the global data that we have, as you see here, 239,000 new cases and 152,000 deaths. So it's really impressive, I must say. And in that sense, it has not changed a lot over the last 20 years. The genomic predisposition to epithelial ovarian cancer occurs up to 15%. Mostly, we are dealing with BRCA1 and BRCA2 causative genes. The risk factors are, of course, the number of lifetime ovulations, family history, smoking, benign gynecological conditions, etc. All very well known to you. I'm pretty sure about that. So let's see if I can, yeah. More than 2/3 of the patients are unfortunately diagnosed at an advanced stage because the symptoms are quite devious and not recognizable for women. So it takes months before the disease becomes really evident. And that's the reason why so many patients are presenting in an advanced stage. The majority of these tumors are of epithelial origin, and mostly they are the high-grade serous carcinomas. And as you know, from more recent date, it's clear that the extrauterine high-grade serous tumors arise from the fallopian tube with clear pre-malignant phenomenon before that. So the symptoms are, as I mentioned to you already, are not very specific. We have additional information, of course, by the tumor marker CA125 and radiologic additional information like pelvic ultrasound or CT scans. But unfortunately, in the general population, that doesn't help very much for screening. And apart from those with family history where the screening might be an option, unfortunately, in the general population, screening techniques are not very helpful. The staging is surgical, and I think what is very important to mention here is that it's very important that this is being done by a very experienced gynecological oncologist. And every woman with ovarian cancer deserves to be treated by a well-trained gynecological oncology surgeon. It's not without reason that sometimes patients are being referred to a more specialized clinic in order to reoperate someone who has been in the first instance operated by a general gynecologist. Sometimes that's needed in order to be informed about how exactly extensive the disease is. So when we talk about the milestones in ovarian cancer, then surgery and the evolution in systemic therapy are milestones. With respect to surgery, lymph node dissection and peritoneal staging in early disease are crucial, while maximal surgical debulking are essential in the advanced disease stages. Now, already for more than 20 years, the use of chemotherapy consists of platinum compounds and taxanes. Although not everyone is in agreement with that, another milestone is the use of intraperitoneal chemotherapy. And more convincing nowadays is the use of targeted agents. And then I have to mention in particular anti-angiogenic compounds and PARP inhibitors. And I think that the PARP inhibitors are as far as I can see, an absolute improvement in the treatment of this disease, although overall survival data, of course, needs to be seen, but most studies have shown very clearly progression-free survival benefit with different targeted agents belonging to the PARP inhibitors. So without going too much extensive about staging, basically it's important that we separate the early stages from the late stages, and staging up to 2A separates the early stages from the later stages. And I think this can be found in all the detailed references that you see at the bottom of the slide, so I'm not going into details about this. But it suffices to say that when we talk about ovarian cancer, it's not one disease. There are different types of ovarian cancer, different in the way they present, different in the precursors that they have, different in presentation and in the way the spread is being seen. And also in terms of molecular genetics, there are clearly differences between the different types. And as you can see, the main types here mentioned on these slides are high-grade serous carcinomas, the clear cell carcinomas, endometrioid type, mucinous type, and the low-grade serous tumors. So when we start talking about the treatment and start first with early disease, then you have to realize that grade and the completeness of staging are extremely important prognostic factors. Patients who belong to the low-risk group, basically well-differentiated tumors confined to the ovary, they have a very good prognosis when you are sure that they have been have had the operation by a well-trained gynecologic oncologist. You see the 5-year survival is 95% or more in these cases. However, several studies have shown that beyond that stage and grade, the patients do need adjuvant platinum-based chemotherapy. And I think very crucial information came from 2 large trials, the ICON-1 and the ACTION trial in the EURTC, showing there was an improvement in the 5-year overall survival from 74% without chemotherapy to 82% with. Now, an important question is, when you give chemotherapy, how many cycles do you give? And there has been an interesting study reported by Bell et al. Already in 2006 that were looking at 3 versus 6 cycles. And although there was no statistically significant difference in outcome, it was clear that there were more patients that had recurrences when they used the 3 cycles than when they used the 6 cycles, at the cost, of course, of more toxicity. But looking who these people are that are benefiting, it's mainly the group that has high-grade serous tumors, as you see here, where you see the curves in yellow belonging to the high-grade serous tumors, showing that there is a clearly benefit when using 6 cycles over 3 cycles. And basically it means that those at high risk for recurrence with early stage disease should be treated like they have an advanced stage disease. Concerning the management of advanced epithelial ovarian cancer, there are in fact 2 categories of patients. You have the ones where you consider that primary debulking is possible, and you have also a category of patients where you have much doubt whether adequate debulking upfront is possible. Now, these two categories of patients are treated a little bit different, because those that may be approached by primary debulking surgery, you aim for complete resection of macroscopic disease. And in the other group, basically the ones that are not fit enough to be operated because they have, for instance, massive ascites and massive pleural effusion, then you start with chemotherapy, or neoadjuvant chemotherapy, if you want to call it. And then mostly after 3 cycles, there will an interval debulking take place. And again, trying to remove as much macroscopic tumor as possible. So the extent of residual disease after the surgery, whether it is primary debulking or interval debulking, is very crucial for the further outcome of the disease. So therefore, it's highlighted, as you see here, that the situation post-surgery, but before chemotherapy, you see that residual disease is on top. It's extremely important. Of course, we are giving much attention to molecular markers, and I mentioned to you already the BRCA1 and BRCA2, but there are several other markers that indicate that there may be homologous recombination deficiency, by which we may select, again, PARP inhibitors, as I will mention to you later. I think it's also important how the disease is responding to the chemotherapy, and therefore the fall in CA125, whether it's rapid or delayed, is an important marker for that. So I mentioned to you already that in 20 years' time, there was not so much difference in the type of chemotherapy that we are giving. So basically, it is 3-weekly paclitaxel at the dose as indicated here on the slide, and intravenous carboplatin, again, given every 3 weeks with an AUC of 5 to 6. However, although that is being accepted as a standard, there has been no other regimen that really outperformed that combination. And I must admit that if you look at the results, that's still disappointing. So there's absolutely room for improvement. Now, of course, you can say this is standard, but are we using only this regimen, or are there alternatives? And I think that the guidelines, both the ESCO guidelines and the NCCN guidelines, are showing that there are several alternative schedules or routes of administration. And you see the list here. So Taxol carbo can be given alone or with bevacizumab, an anti-angiogenic compound, as you know. And that is basically on the basis of the results that we have seen in the ICON 7 and GOG 218 protocol. Docetaxel and carboplatin can be used when there is a contraindication for using paclitaxel. You can administer the paclitaxel also in a weekly regimen. You may use, instead of taxanes, also pegylated liposomal doxorubicin. And then there are 2 options that are mentioned clearly in the NCC guidelines, but are not endorsed by the ESCO guidelines, and that's the use of intraperitoneal chemotherapy in stage 3 patients after primary surgery, and the HIPEC use in patients during interval debulking surgery in stage 3 after neoadjuvant chemotherapy. Now, concerning the targeted therapies, you see there are many targets, in fact, that could be used with different drugs that you see on the right side of the slides. But I highlighted in yellow the 2 targets that are of importance in daily practice, and that is PARP. And you see here at least 4 compounds that are of interest: olaparib, veliparib, niraparib and rucaparib, and then the angiogenesis compounds, of which bevacizumab is the one that is used most, as I mentioned already, based on the ICON-7 and the GOG 218 trial. So these two targets are of importance. Now, for a long time, we have, when we treated patients with recurrent disease, according to this sort of frame that you see here, that means if they had platinum-resistant disease, we're defined as a platinum-free interval of less than 6 months. These patients are candidates for non-platinum single agents. And when they are platinum sensitive, that is a recurrence beyond 6 months after the primary treatment, they are candidates for combination chemotherapy, and basically, again, platinum-based. But you see there are, again, differences for those who have 6 to 12 months interval or more than 12 months, which we consider as fully platinum sensitive. Nowadays, we realize that it's not only platinum that is important, but it's the way, number one, how the recurrences are detected. Is it on the basis of CA-125? Is it on the basis of radiological techniques or clinically? And also, what do we do with these maintenance therapies that we are using nowadays? So the platinum-based interval has been replaced largely by a therapy-free interval, which is important to consider. Now, if we start with anti-angiogenic therapy in recurrent ovarian cancer, there are at least 4 trials that clearly showed a benefit in terms of progression-free survival. So in the platinum-sensitive disease, it's the OCEAN trial and the ICON-6 trial, and in the platinum-refractory disease, which is basically absolutely a very important observation because we didn't have much for these patients. The Aurelia trial was a very crucial trial, clearly showing benefit of adding bevacizumab in those patients. I think it's really the first time that it's really had some impact in these patients. In the primary disease setting, as I mentioned to you, the GOG 218 and ICON-7 are important in what we can expect from adding bevacizumab to the cytotoxic chemotherapy. It results in a difference in progression-free survival around 5 to 6 months. And the duration in the 2 trials of treatment has been 15 months in the US trial and 12 months in the UK trial. Now, I must say, at ESCO this year, there was a large trial that compared the duration of 15 months versus 30 months, 30. And the outcome of that trial showed that there was no difference. So at this moment, I think that the duration of bevacizumab should be the 15 months as a routine when you plan to use it. So the toxicity is acceptable. You're very much aware of the risk of hypertension. But for instance, the gastrointestinal perforation, which is of course a very serious complication, is fortunately being seen at a low percentage, as you see here. I think one of the important information from the ICON-7 trial was that the use of bevacizumab in the primary disease setting, the benefit of that was mainly seen in the patients that were at high risk for recurrence. So the advanced stage 3C disease and stage 4 disease, while in the other category of patients with smaller lesions, with less risk of recurrences, the difference was not significant. So if you compare the results of bevacizumab in the recurrent ovarian disease setting versus the primary disease setting, I would say that in the recurrent disease setting, the use of bevacizumab is even stronger than in the primary disease setting. And I think also in my institution, we reserve the use of bevacizumab in the patients with high risk for recurrence in the primary disease setting. Now, finally, the PARP inhibition, as you're very much aware that the effect on single-strand breaks that normally are being handled when they go to double-strand breaks in normal cells will be repaired when PARP inhibitors are being used. That process is inhibited, in particular in cells that have HRD, homologous recombination deficiency. Fortunately, the use of these compounds is not leading to a very high toxicity. It's also clear that it's not only working in BRCA mutated cases, but it extends to a much larger group of diseases, and over 50% of the patients might benefit from the use of PARP inhibitors. It initially, and I start now with the role of PARP inhibitors in recurrent disease setting. It started with the three drugs that you see mentioned here on the slide: olaparib, niraparib, and rucaparib, where the data with olaparib were first reported in 2012 by Jonathan Lederman. And you see here that in those trials, we were dealing with platinum-sensitive high-grade ovarian cancer with at least the 2 previous platinum regimens. And the patients were showing sensitivity to that last chemotherapy that was platinum-based before they were using the PARP inhibitor. So they should have at least stable disease, but preferably were responding to it. And you see here the use of olaparib was given in 400 milligrams orally, 2 times per day, and the control arm did not use maintenance therapy, was using placebo. And you see here that there was clearly a difference in outcome in the patients that used maintenance olaparib versus placebo. And in a retrospective analysis of the same study, it was found that if you looked only at the patients with the BRCA mutation, and there were, as you see here, 136 patients out of the 200 so odd patients, the hazard ratio went down to 0.18. So really a very strong signal of efficacy here. And you see here the median progression-free survival in this cohort was 11.2 months versus 4.3 months with placebo. Now this has been confirmed in 3 other studies: the SOLO-2 study with olaparib, the NOVA study with niraparib, and the ARIEL-3 study with rucaparib. They were all done in patients that had BRCA mutation, but in the niraparib, all comers were included. So also patients who didn't have BRCA mutation, but had HRD positive tumors and even HRD negative tumors. And you see that very consistently, the benefit in progression-free survival was seen in all these confirmatory trials. And I think that makes the information on PARP inhibitors very solid. You see also in terms of hazard ratios in the 3 studies in the patients who had BRCA mutation were quite consistent. So if you look at the ESCO guidelines in recurrent disease as it was published, I think in 2019, then first you select the patients who are potentially platinum sensitive and those who are not. If they are not, if platinum is not the best option, because they have, for instance, an early symptomatic relapse or were progressive on prior platinum or could not tolerate it, then a non-platinum therapy is being advised, most probably on the basis of the Aurelia trial with bevacizumab, if there are no contraindications for that. But in the other group where the use of platinum is important or could be important, depending on how the symptomatology was and whether there are contraindications for bevacizumab or not, the patients can be offered platinum-based re-challenge plus bevacizumab or re-challenge with PARP inhibitors. But things go fast in this disease. So PARP inhibitors, we're moving out to the first line setting. And there are 4 trials, the VELIA trial, PAOLA-1, SOLO-1, and the PRIMA study, where the different PARP inhibitors were used in the first line setting. So the SOLO-1 was using olaparib versus placebo maintenance in the BRCA mutation cases after response to platinum-based chemotherapy. The only trial where the PARP inhibitors was also combined with the chemotherapy, followed by in maintenance or using it during the chemotherapy followed by placebo or the chemotherapy alone. That's the only trial that looked at that specifically. And I think that on the basis of the data that we have in the PAOLA-1, SOLO-1, and the PRIMA trial, these 3 drugs have been approved by the FDA and EMA for the treatment in the first line treatment of ovarian cancer. So you see here the data, and I put here up the difference in progression-free survival and the hazard ratios. So you see that if you start with the SOLO, you see that the hazard ratio is 0.30. And if you go to the PAOLA-1, where the patients have been treated with chemotherapy plus bevacizumab, and then continued with bevacizumab with or without the PARP inhibitor olaparib, you see that in the intent to treat population, it was significant. In the homologous recombination deficient group, it was significant, but it was not beneficial in the patients who had negative homologous recombination deficiency. And the only separate, the different outcome here is the PRIMA trial, where also patients which were HRD negative showed a significant difference. So that is, I think, a very important difference with the niraparib versus the other 2 compounds. So the updated information that came this year in a paper from Dr. Nicoletta Colombo and Jonathan Lederman is that in SOLO-1, the 5 years data show 48% progression-free survival versus the control arm 21. The PAOLA-1, the greatest benefit was in the BRCA mutations, somewhat less, but still quite significant in those who had HRD positive disease, and no benefit in HRD negative or unknown cases. In the PRISMA, as I mentioned already, there was the difference that also in the HRD negative cases, there was benefit. Now, in terms of toxicity, if you look at the toxicity with olaparib, niraparib, or rucaparib, overall, it's reasonably tolerable, but about 10% of the patients have such adverse events that they stop the treatment. And therefore, it's remarkable that, of course, the expectation was already that combined with bevacizumab, that percentage will go up, and that's true. That's what you see here. And also, when you combine it with chemotherapy, the number of patients that stop the treatment is higher. But overall, in the other disease, in all the other studies, you see it's about 10%. Treatment-related deaths are low, but there is a slight increase in hematologic malignancy, like AML and MDS. So not to such an extent that it seems to be a danger at this moment, but it's certainly something that we need to follow up when we talk about 5 to 10 years follow-up of these patients. And finally, one slide on immunotherapy. Immunotherapy at this moment, which is so attractive in treatment of endometrial carcinoma and in cervical carcinoma, has not shown the same benefit in patients with ovarian cancer. The checkpoint inhibitors, the immune checkpoint inhibitors, are able to induce responses in 6 to 22%. And when it occurs, some of the responses are long lasting, and that's in line with what we see with other responses in other diseases. But it needs further assessment in this disease. And what I show here is that the checkpoint inhibitors are being studied in combination with different other compounds, in combination with chemotherapy, other immune targeting agents, in combination with anti-angiogenesis therapy and with PARP inhibitors. So that needs further study before we come to a final conclusion on that. So the take-home messages from what I presented to you is summarized here in 2 slides. So it's still clear that upfront surgery should have priority. When it's possible to debulk a patient upfront, that has priority over using neoadjuvant chemotherapy. It's only on indication that when you think that upfront surgery is not possible adequately, that you should change to neoadjuvant chemotherapy. 6 cycles of Taxol carbo is standard, and I would say with or without bevacizumab. That you see that here. Intraperitoneal chemotherapy in HIPEC can be considered in specific situations. It's also put down as information to patients in the NCCN guidelines, but it's, as I mentioned to you already, it's not supported by the majority of gynecologic oncologists working in Europe and following the ESCO guidelines. Personally, I think there is a role for this approach, but I clearly agree with the fact that it is more complicated. You need to admit the patients in the hospital, and it is clearly less easy than using a drug that can be given orally. So in that sense, I agree, but I think that in specific situations, there is a role for that. And there are ongoing randomized trials in the first-line setting, ongoing in Europe. PARP inhibitors have an established established role and is at this moment the new standard of care. All patients with high-grade ovarian cancer should be tested for BRCA1 and BRCA2 mutation at diagnosis. Patients with BRCA mutation and response to frontline platinum-based chemotherapy should receive maintenance PARP. That is 2 years olaparib or 3 years niraparib. Olaparib and bevacizumab should be used when bevacizumab is added to the frontline chemotherapy. Testing for HRD is recommended, and patients with positive HRD tests and response to platinum-based chemotherapy with or without bevacizumab should receive maintenance PARP inhibition, either olaparib, bev, or niraparib monotherapy. And with that, I thank you for your attention, and I'm looking forward to your presentations on the cases that you have prepared.
Thank you, Professor Vermorken, for your impressive presentation, very useful information, and we will discuss questions during clinical case presentations, and I want to ask to participants to send questions, and we will discuss it later. Please allow me to share my screen, and let's start discussion of first clinical case. I think that today is very important day because we are discussing diagnosis, which is the most common cause of cancer death from gynecological tumor. My clinical case is about early stage ovarian cancer. And my patient is 63 years old woman, and from the past medical history, she was operated because of rectosigmoid tumor in 1999. She refused to have any adjuvant therapy, but she has no any paper about her clinical status, past clinical status. She has no family history. In June 2021, she had abdominal pain and distension, and by the ultrasound examination, up to 10 centimeters tumor mass was revealed in the pelvis, and gastroscopy and colonoscopy were normal, and chest CT of chest and abdominal CT revealed no distant metastasis and no free fluid in the peritoneal cavity. Tumor markers were not performed. This patient was diagnosed with early stage ovarian cancer, which is very rare diagnosis, and mostly it is found by ultrasound examination for other reasons. And the surgery is often used as the first step in treatment management. We need to have surgical treatment to confirm the diagnosis, extent of disease, and remove all visible tumor mass. In July 2021, she was operated, laparotomy, hysterectomy with bilateral salpingo oophorectomy, and lymphodissection and ometectomy were performed. Pathological diagnosis was consistent with high-grade serous ovarian cancer, stage 1C, grade 3. She came to our hospital for next recommendations, and I want to say that we should remember that ovarian disease is not one diagnosis. It is not diagnosis just for surgeon or clinical oncologist or radiologist. It's the key point management is based on multidisciplinary team decision, and we should stand very closely together. And the aim of treatment is to obtain complete remissions through surgery and chemotherapy. Our recommendation about adjuvant therapy was based on clinical trials, which were performed several years ago with patients with early stage ovarian cancer, ICON 1, GOG 153 and 175. And these clinical trials were addressing to the role of adjuvant chemotherapy, the number of cycles chemotherapy, and the role of maintenance chemotherapy in adjuvant settings. We should remember that epithelial ovarian cancer has a different molecular profiling, and they look differently under the microscope, and they behave differently. And the problem of this clinical trial was that histological types varies according to each clinical trials, and it's a little bit difficult to make key point decision from these clinical trials. But if we see next paper and the result of these 3 trials, we can see that overall survival looks quite good in contrast with advanced stage ovarian cancer. And the difference between 3 versus 6 cycles of chemotherapy is minimal. Our recommendation was 6 cycles of chemotherapy, adjuvant chemotherapy, because for unfavorable histology, even for grade 1 disease. And from the future recommendations, we recommended BRCA1 and 2 germline mutation because we know that ovarian cancer present a various molecular profiling, and 20% of them is germline mutation of BRCA1 and 2. And according to NCCN, ESMO and ESCO guidelines, it's all women with ovarian cancer should be screened for BRCA1 and 2 mutation. And also follow-up regimen was recommended. My questions to the faculty are following. Is chemo always needed in early stage ovarian cancer, for example, for stage 1 AG2 or endometrioid histological type? How does cancer histology impact on your choice of adjuvant therapy? And what do you do if the patient had low-grade serous ovarian carcinoma? What are the number of cycles you are recommended for early stage ovarian cancer? And how can we choose patient for secondary debulking surgery? Thank you so much.
So do you want me to start with that, or should Dr. Sessa start?
Maybe we will.
Well, Jan, you should start.
Okay, that's fine. That's fine. Well, you have a lot of questions, Mariam. So, and I think they are important questions, and they are really related to daily practice, I think. Well, to say, I think that everything that is not well differentiated and confined to the ovary, so not grade 1, not well differentiated, you have to discuss whether you would give the patient chemotherapy. I think that would be my advice, but it may be that Dr. Sessa had a different feeling about that. But I think that's how we always did it. If it's not well differentiated and there is no tumor on the surface and there is no spilling, then everything beyond grade 1, you should consider chemotherapy. And the number of cycles, well, you mentioned 3 versus 6, but I think that basically when you decide to treat with chemotherapy, you should treat it as if it is advanced disease. Otherwise, I don't see the role of any form of adjuvant therapy if you have a feeling it's different than considering it advanced disease. Your question about low-grade tumors is interesting. I think that whatever the histological type, whether it is mucinous or clear cell, or it is high risk, or it is low risk serous tumors, the approach to these tumors is the same. So it's you treat them with surgery, and when there is an indication for chemotherapy, you give also the same chemotherapy. And I realize that the efficacy of that chemotherapy is different in the different histological types, but we have nothing better at the moment. And so that means that there are studies ongoing in the specific subtypes to see whether some forms of chemotherapy are better than the standard ones. And as far as I know, we have not discovered that. Of course, in some of the low risk, the low-grade serous tumors, you may consider adjuvant treatment with hormones after the chemotherapy. That is a possibility. There are suggestions from Gershusen in the United States that the use of letrozole or of Arimidex in these circumstances may have some effect. Also, MEK inhibitors have been used, but that's basically in recurrent disease. I think that hormones in the adjuvant setting is something that may be considered. How to select these patients, that's difficult for me to say. I don't know whether, Christiana, you have any suggestions who should be selected for that. Only saying that whether there are hormone receptors, I don't know whether that is enough.
Yeah, I fully agree, Jan. I think that there are not enough data to correlate the presence of the receptor to hormonal treatment to a response. Yeah. And the data you refer to, they are related to the introduction of hormonal treatments at the time of recurrence after an initial chemotherapy. So I fully agree with what you said. The mainstay of treatment for low grade is a surgery. And also at the time of recurrence, it's important that if you have some macroscopic disease, you can again reintroduce surgery, even though it's not complete, even though you cannot get a cytoreduction. Yes. But that's the only way to decrease the burden, substantially the burden of the tumor. There has been discussion also on the potential role of bevacizumab, but the point is that there are no data. And I think also it's important to clarify that there is no indication at all for the use of PARP inhibitor in first-line treatment in low-grade disease. So all the data Jan mentioned, they are related to high-grade because the tumor growth is completely different. And this is the problem. Then so the point is that if you have serous low-grade, you can discuss some chemotherapy. If you have endometrioid low grade, there are really not enough data. So it's again something to be discussed with the patients. At the time of recurrence, I think, in my opinion, but Jan, is something I like to share with you. It depends very much on the interval from the end of the initial treatment and the recurrence, because sometimes you see that you have quite an early recurrence of the disease. And in this case, if it's feasible, it would be nice to repeat a biopsy of the tumor because perhaps something is changed. And we know today that, in the past we thought that low grade and high grade are two completely different entities. However, today we know that there could be a kind of differentiation where you start with some borderline disease, and then at the time of recurrence you find a low grade, and then eventually at the time of recurrence you find some undifferentiated high grade. And there are series of patients where one of them was already published by Zanoni, the other one was discussed at the observatory, ESO observatory at the ESCO Congress, where you have this mixed entity, and overall the prognosis is very bad. They are usually younger patients with the low grade initially, but then you have a completely change in the characteristics of the tumor. So that, I fully agree. I think that today what we can say on low grade is that we know that surgery is important. It's important also at the time of recurrence. And then the treatment is, it's important to individualize the treatment. I don't know, Jan, if you agree, but there are not consistent results because it's a rare disease.
Yes, and I think also that sometimes we see patients where you're starting with a low grade serous tumor, and then the behavior seems to become different, and they have a more rapid evolution, and then you decide at such a moment that you should treat it as a high grade tumor. So that must mean that or there is a de-differentiation or there is an heterogeneity in the tumor by at certain moments one may be preponderance over the other, and that means that you have to adapt your approach to the patient very much individually, and you have to discuss this in the multidisciplinary tumor board in order to take all these changes in the behavior of the tumor in that individual patient very carefully, and then decide which treatment modality has preference at that moment. So I think it's a very complex situation when it concerns low-grade serous tumors, I must say.
And another advice, perhaps, it could be important to have a revision of the histology, because that's really essential, the role of the pathologist. So if you're not really convinced, you can ask for a revision by expert gynecooncology pathologist. Because it's strange. The point is that it's a difficult diagnosis anyway.
There is one thing that I would like to mention, and that is that we should be aware that some patients have a very particular recurrence. That means some of them are recurrent only in lymph nodes, sometimes in the abdomen, sometimes in the mediastinum. And some of these patients may benefit from local treatments. And I think that there is a lot of attention at this moment, not only in gynecologic cancer, but at different tumor types, on the role of oligometastatic disease. And so the role of SBRT, for instance, for some of these patients should be considered depending on if they have a very localized recurrence, because the survival of these patients may be completely different and much longer than the general, widely spread disease. And I think that is something that is getting attention in the last 5 years. And there is a lot of data in the literature coming up about that.
Yeah, I agree with that.
Thank you so much. From my practice and in our clinic, we recommend 6 cycles of chemotherapy even for patients with stage 1 with unfavorable histology. And for other patients, we recommend 3 cycles of chemotherapy, even for stage 1 and 2 with unfavorable histology. And my last question was, who is a candidate for secondary debulking surgery?
Oh, yeah. Well, as you know, that the AGO group in Germany has done a lot of work on secondary debulking, and they made a sort of scoring, and the patients that are benefiting from secondary debulking are the ones that had a complete response on the primary surgery, had hardly any ascites if they had it less than 500 mils, and had a 0 performer status according to ECOG. So these patients, when the situation presents that they have a recurrence, are candidates for surgery. The desktop 3 trial that was recently reported at ESCO 2020 showed that there was survival benefit in the randomized trial comparing chemotherapy plus surgery versus chemotherapy alone. And of course, the benefit was mainly in the patients that reached a complete response. But I think that if you make use of the AGO scoring, then you have a fairly well separation of the patients that potentially might benefit from surgery.
Yeah.
Thank you so much. Yes.
Can I ask you something which is related to, Jan, to your presentation?
Yes.
Because, you mentioned that HRD, the homologous recombination dysfunction, is very important because in some way identifies patients who have a kind of intrinsic sensitivity to platinum. Let's put it this way. Yeah. They have a genetic abnormalities in the mechanism of repair. Yeah. So my suggestion, and I think overall for everybody, if you don't have HRD available, the test, because there's a lot of discussion on which is the best method, the myriad one has been criticized because we don't know really what is inside and so on. The main principle to decide to reintroduce platinum combinations and also to add PARP inhibitors to reintroduce a response is the time interval from the end of the treatment and the start of the treatment. So, clinically as well, you can decide if it's worthwhile to reintroduce platinum, even though you don't have the HRD, because that could be another criteria for screening patients. But look at the family history and also at the clinical history. And that I think is very important because, for example, if you have a patient who received already 2 lines of chemo, because she responded to the reintroduction to a platinum combination, and then 6 courses, and after some time relapsed again, and again reintroduced platinum, that's clearly something in that patient which suggests that next time PARP inhibitors should be added.
Yeah.
That I think it's important.
Absolutely, absolutely. You mean even when you don't know the HRD or the BRCA mutation, even when you don't know it, that is a suggestion to use it.
Yeah.
Yeah, but the problem is, of course, that not in all countries the payment is being handled like that.
Yeah, yeah. And also the other important point, I appreciated very much in your presentation, Mariam, that you put testing BRCA1/2 germline. So I think what is important is that it's not only for therapeutic reason that we want to test those patients, but also for the family risk. And also that there are data showing that there's a quite a, relevant discrepancy between the tumor testing and the germline testing, because there are cases where the tumor mutation is negative, while you have germline mutation in some particular pathogenic variant. And germline is also very important for to establish the family risk. So I think you should start with that.
Yes, thank you so much. Thank you. We can move to clinical case number 2.
Yeah.
And our clinical oncologist, Saba Kopadze. Please, Saba.
Hello.
Thank you so much.
Thank you. My name is Saba Kopadze. I am medical oncologist from Tbilisi, Georgia. I work in Caucasus Medical Center. I am very pleased to be given this opportunity to take part in this webinar and hear your recommendations about these diseases. And thank you, Mariam, for this opportunity. Now I will share my screen and begin. So my presentation is about advanced epithelial ovarian cancer. This is a 63-year-old woman, Caucasian, who was presented in our emergency department with complaints of abdominal pain, increase in abdominal size, constipation, and difficulty in breathing. Her past medical history was unremarkable. She had no family history of cancer or any of the chronic diseases. Physical examination revealed abdominal distension, right lower quadrant pain, tenderness, and palpation, and her ECOG performance status was 2. So on initial workup, chest and abdominal ultrasound was done, and it revealed massive right-sided pleural effusion and ascites. Paracentesis was done with evacuation of this ascitic fluid, and on cytology there were no malignant cells detected. On chest, abdominal, and pelvic CT scan, there were bilateral lung metastases up to 11 centimeters maximal size, peritoneal carcinomatosis, and peritoneal carcinomatosis and right ovarian mass. Gastroscopy and colonoscopy was done. It revealed no malignant lesions, and for diagnosis, for diagnostic purposes, laparoscopic biopsy from peritoneum was done, and the diagnosis was high-grade serous carcinoma metastasis. Cancer antigen was elevated, and BRCA and homologous recombinant deficiency status is unknown because PARP inhibitors are not reimbursed in Georgia, and most of the patients can't afford nor the treatment or this testing, and so we could not perform this molecular analysis. And this final diagnosis was high-grade serous ovarian cancer, figure 4B, because of this chest pulmonary metastasis. So we decided to start with chemotherapy with carboplatin paclitaxel every 3 weeks. After 3 cycles, there was on restaging CT scans, there was a reduction in number and size of lung lesions, as well as ovarian tumors. There was no visible pleural effusion or ascites, and it was a partial remission. After 3 cycles, this patient's condition was complicated with neutropenic fever. She was hospitalized, treated with IV antibiotics, growth support, and so we reduced the dose due to polyneuropathy grade 2. Another 6 cycles were done. After 6 cycles, there was a complete response in the chest with no visible metastasis or pleural effusion. Also, no visible peritoneal carcinomatosis. There were no visible peritoneal lesions, and there was a reduction in the size of right ovarian mass. Cancer antigen was in normal range. So on MDT meeting, we decided, which included this gynecologic surgeons, we decided to proceed with surgery. And so surgery was done with hysterectomy, bilateral salpingo-oophorectomy, and final pathology report was high-grade serous carcinoma, FIGO-A1, and chemotherapy response score was 3. Good response on chemotherapy. So my questions now are, would you consider platinum doublet plus bevacizumab as an initial treatment? Because several trials, including ICON-7, supports its use, because in high-risk group, you have spoken already about this, FIGO-4 and other high-risk factors, bevacizumab showed overall survival benefit, as well progression-free survival benefit, and overall survival benefit was about 5 months, but only in the high-risk group. Another question is, would you recommend surgery to this patient, considering that after 6 cycles of chemotherapy, there is no visible lesion in both lungs, and also good response in the abdomen? My third question is, can we offer bevacizumab maintenance to these patients? We know that PARP inhibitors are not available in Georgia because of these financial concerns, and we know that bevacizumab is recommended when it is used in the first-line setting with platinum chemotherapy, but there is no randomized trial data to support its use if it was not used in the first line with platinum chemotherapy. So I want your opinion about bevacizumab maintenance in this situation. My first question is best treatment option for platinum-resistant progression. We know that single-agent chemotherapy plus bevacizumab showed PFS benefit about 4 months with no significant overall survival benefit, and also there were no new adverse events in this trial. And we know that monotherapy is recommended after platinum-resistant progression, and which single chemotherapy agent do you recommend from your experience? And my last question is benefit of endocrine therapy for those who relapse only by cancer antigen, but when there is no evidence of radiologic progression. We know that we can wait and start the treatment when there will be progression, but some patients prefer to proceed with treatment, and I want your opinion about endocrine therapy for these patients.
Right. Can you hear me?
Yes, yes.
Okay. So, yeah, the problem, of course, is that in some countries, not all drugs are reimbursed. I mean, you can understand that that's a problem. And we are facing that also in the country where I am working. So it's not unique that that is happening. But theoretically, if I have to answer your different questions, I think this would have been an excellent candidate for chemotherapy plus bevacizumab. I mean, it's a very advanced disease with pulmonary metastasis, and I think that the data from ICON-7 clearly suggested that in these circumstances, the addition of bevacizumab has benefit in terms of progression-free survival. So I think that if you would be able to prescribe that in your country, I think that would have been a reasonable alternative for what you did. You had a wonderful response. I mean, but you never can predict that beforehand. Yeah. So it's always that you have to balance the toxicity versus the benefit that you may obtain. And you can say, well, this patient did, extremely well, and that's fine for her. But if beforehand you don't know what to expect, I think you should then start to give the regimen that has the greatest chance to respond and to have an adequate progression-free survival. Concerning your surgery question, when patients have intrapulmonary metastasis, we normally would not go for surgical debulking. Surgical debulking is considered also in stage 4, but mainly for the patients who have stage 4 on the basis of pleural effusion. There we do that, but to have lesions in the lung, I understood that the patient had lesions in the lung, right? Is that correct?
Yes, it's correct. But this maximal size of these lesions was about 1 centimeter, and after 6 cycles, there was complete response in the chest, and
yes, but still, I mean, the fact that there are parenchymal lesions, I will have some doubt. Moreover, you did not consider interval debulking. You considered to do surgery after the end of chemotherapy, right? In the past, we have done that also, and you could actually say that it's a sort of second look surgery, which is basically then the moment that you decide whether there is another treatment for maintenance or otherwise. And otherwise, I think that after 6 or 9 cycles to do the surgery, there's no clear data that will ultimately have a beneficial effect on outcome. But again, I like to hear also Dr. Sessa's opinion about that. I think I would not do that. But it's just your question about what maintenance therapy. Well, if you would have started with bevacizumab, I would certainly give that patient 15 months of bevacizumab after the chemotherapy. So, and if you would be allowed to give a PARP inhibitor, this patient would have been a potential candidate to use it in first line in the maintenance setting, but then in addition to the bevacizumab, I think. Your question about the Aurelia study, the Aurelia study is something that is a study that has been performed in patients with platinum refractory disease. So that's not an issue here. We are talking here clearly of a platinum sensitive disease. So
I'm sorry, I'm not asking about.
I don't understand the question exactly about the best treatment option for platinum resistant progression. Yeah, you mean later on? Yes, if you
Yes,
would
later on, if
yeah, I understand. I understand. Yeah, if the patient would recur,
yes, yes.
and then I would consider to use a single agent chemotherapy plus bevacizumab, like you have done, like it was done in the Aurelia study.
And which chemotherapy agent do you recommend? We know that there is no first line in sepsis.
Well, pegylated liposomal doxorubicin would be an option, for instance, together with bevacizumab. That is a possibility. That drug is also available in your country?
Yes, bevacizumab is available.
Yeah.
Yes.
It's a little bit depending on whether the patient has late effects from the taxanes or platinum, whether they have, in particular, whether they would have neurotoxicity that is, persisting. Otherwise, also a taxane could be considered together with bevacizumab. But I think the PLD is an attractive drug. It is well tolerated by patients, so that could be an option together with bevacizumab. Concerning endocrine therapy, well, I remember that Dr. Markman in the US was one of the first who was using hormone therapy in patients who had relapsed that was not accompanied by clinical symptoms. And it is something that we also sometimes do. If you just have a CA1 to 5 elevation, without any symptoms and very, very small lesions that are not even can be followed by CT scan, then I think the use of hormone therapy, especially when the patient is aware of the fact that there is potentially a recurrence and is very eagerly demanding a treatment, then that is an option you could consider. It's not necessary to do so, but you can do it. And according to the data from Dr. Markman, you have the feeling that sometimes this can keep the disease for some months in a stable situation. So there's nothing wrong with it if you do that.
Can I add something? To you.
Sure.
So if I can give my answers, let's put it this way, I fully agree with you that these patients could have been a good candidate for bevacizumab. Also, according to the ESMO guidelines, because you've seen at the beginning of the algorithm that if you have, effusions, or if you have a rapidly growing disease, and so on, it would be useful to add BEV from the beginning after the second cycle of treatment if the patients had surgery, because it can improve quickly the performance status and can decrease the burden of the disease. I think that sometimes it's true that you should try to have the debulking surgery during the treatment. However, after 3 cycles, perhaps you haven't achieved the maximum of the response. So perhaps you want to decrease further the tumor burden, as it was in this case, because after 3 cycles, you checked the response and you've seen that the lung lesions were still there, as well as the peritoneal carcinomatosis, which was not clearly an indication to perform debulking surgery at that time. And then after 6 courses, there was a complete remission. However, you didn't have the CA 1 to 5. You can't exclude that there was still some resectable disease in the peritoneum. And also you see complete responses in the lung. I think at that point, we would have done debulking surgery or second look laparotomy to be sure that all the tumor had been removed, because it looked like a very extensive disease and aggressive disease at the diagnosis. At this point, if Bev had started with chemotherapy from the beginning, it could be added as a maintenance, because there is no reason to give Bev after chemo. Bev should be should be given together with the first 6 cycles of chemotherapy, because those were the data in the GOG study which showed that there was an improvement in the progression-free survival. So as regards the comment on the Aurelia study, we fully agree with all the limits of the Aurelia study. However, the point is that in the Aurelia study, which brought to the registration of BEV in combination with chemotherapy, without specifying which was the chemotherapy to be added, was the improvement in the quality of life of the patients. So it was not the improvement in the progression-free survival, which was limited, but they were difficult patients with refractory disease. And that there's no study, let's say, so far that they're shown a clear improvement in the overall survival in ovarian cancer with the first-line treatment because of the characteristics of disease. As Jan said, we hope that in the SOLO-1 study, we'll see some improvement in the survival in a longer follow-up. But the history of ovarian cancer is built on the treatment of the subsequent steps, of the subsequent recurrences. And then it's difficult to say how much was relevant in the initial treatment. BEV, you know, have a response curve which closed at the end. So there's a crossing of the 2 lines. For the PARP inhibitor, so far, we haven't seen a crossing of the 2 survival curve. They are parallel and they have plateau. And this is the important point with the PARP inhibitor. So that's, you know, I think that, again, there are particular situations. So it's always useful to discuss within the team, because that's also the surgeon who should say, okay, I think I can do a complete site reduction, or saying, well, no, listen, it's useless to do that because there's still something in the abdomen, and I think I cannot resect them. I don't know, Jan, if fully agree, but
yeah, but the problem, I see the difference between what you said and what I said is that you would consider surgery also when you have multiple lesions in the lung, parenchymal metastasis. And I must say that that is, I mean, you will never be able to remove the lesions from the lung, right?
No, so, but the lung was in complete response.
Yes, but for what it's worth, of course. I mean, it is radiologically a complete response, but I don't know whether it is pathologically a complete response.
Wow, it depends on the, we'll see on the follow-up. We want to have the follow-up of these patients.
No, I will inform you about follow-up results.
Yeah, that would be nice. But I think there is, of course, another reason why bevacizumab would have been an excellent choice to start from the beginning, and that is that it has a beneficial effect on the development of ascites. And in that sense, I think bevacizumab is a very attractive drug in patients who have ascites. And the only advantage that I see is in the operation is that you remove the omentum, which also plays a role in the development of ascites. but whether it would really have an impact on survival, I'm absolutely not so sure about that. So you see, that's the interesting thing of discussing such patients in the multidisciplinary meeting. You have different views about the role of different approaches, and we learn a lot from each other by discussing this.
Yeah, yeah.
Thank you very much for your recommendations. And
thank you so much.
The patient is still alive, I hope.
She's still alive, yes.
You're still in response, I hope. As well.
Just completed this operation about 3 weeks ago, and now it's new case.
Yeah, okay. But the patient stopped the treatment now.
Yes, because no PARP inhibitors and
Yeah.
Okay. Yeah, perfect.
So let's move to the second part of our webinar, and the speaker is Dr. Christina Sessa. She is from Switzerland, and her presentation is dedicated to endometrial cancer guidelines review. So, dear professor, you can start your presentation.
Yeah, thank you very much. I agree with Mariam that Mariam will move my slides. Perfect. So first of all, thank you so much for the invitation to this meeting, which I think is quite exciting, because we spend already all the time which was in our disposition, and I think we'd like to continue if we can, only talking of ovarian cancer, which means that there was a nice discussion and we wanted to share our opinions on that, and that we have also lively discussion. And I've seen, Jan, that there are many questions in the chat. Yeah. So then we can see how we want to deal with them. So I reviewed the guidelines of in the endometrial cancer. So I wanted to say is that endometrial cancer is the most frequent gynecological malignancies, with the majority in the initial stages of the disease. And in this picture, you can see which are the stages. So it's different from ovarian cancer. The 5-year survival is quite good in these initial stages. The stage 1 is around 95%. No, wait 1 minute, please, with the slide. And I'll tell you, Mariam, when it's time to move to the next one. And the point is that our main concerns today in the management of endometrial cancer is try to understand why there are this 5% of patients with initial stages who have a bad prognosis. And we want to adapt the treatment to the characteristics of the disease. So we start with the stage 1 and also the stage 4, like in ovarian cancer, could be a locally advanced disease with involvement of the bladder and the bowel, or a distant metastasis like in ovarian cancer. The stage 3 is the one which goes in the parametrium, which is the lateral wall of the cervix and under the uterus. And the point, the involvement of parametrium could cause problems related to the compression of the ureter, or to the lymph nodal involvement, because the lymphatic vessels are in the parametrium. Next slide, please. So the point is that we know already they were defined as well at the ESMO consensus conference on endometrial cancer, ESMO, ESCO, and ESTRO, which was done in 2016. And there were 3 risk factors on which the adjuvant treatment was adapted, and they were the grade, the degree of the myometrial invasion, and the lymphovascular space invasion, which related to a higher aggressiveness of the disease. If we can go to the next one. Now, and that was one particular classification. However, today we use a different classification. Well, it's a complementary classifications. And one of the most important findings in the management of endometrial cancer has been the identification or four different genomic classes, 1, 2, 3, 4. And this was identified through a comprehensive genomic and transcriptomic analysis of around, they were about 90 cases of endometrial cancer with also serous carcinoma, serous histotype inside. And what you can see is that they corresponded to different histotype, different tumor grade, and a different prognosis. So the point is that we have this group of patients which are serous-like, different from ovarian cancer anyway, serous. They have this particular histotype, and also, as you can see, that the mutation profile, the genomic profile is completely different, because we go from a low copy number aberrations with methylation and a high percentage of pole mutation, and then I'll explain you what is that. And then we have the classical genomic mutation of endometrial cancer. While if we go to the serous, you can see that there's no pole, there's no PTEN. However, there's a 90% of cells with P53 mutations and some PIK3CA, and also some BRCA mutations, which is not reported here. From a therapeutic point of view, this means that we should have a different approach because the characteristics of the tumor are different. Then we look at another characteristics, which is the macrosatellite instability. You know that there has been shown a good activity of immunotherapy in patients with the high macrosatellite instability, mainly in colon cancer, but also in other tumor, which means that the activity of the immunotherapy is related to these characteristics more than histological type. And this is one of the characteristics of immunotherapy. The mechanism of action is different from chemotherapy. And this is a characteristics of the intermediate grade with the 28% of progression-free survival at 5 years. And then we have the stable disease, macrosatellite instability stable, which is a more difficult disease because we know that immunotherapy so far hasn't been shown any activity. And here, this is the serous with a very poor prognosis and very low overall survival. So it's completely different spectrum. Can I have the next slide? Okay, so this is the definition of the microsatellite instability, which basically is a hypermutability of the cells with accumulations of errors and impossibility of repair. Next one. And can I have the next slide? Yes, and what is important is to remember that this alteration can be easily detected by immunohistochemistry. Then you need some PCR for if you want to identify some specific protein products of the mismatch repair genes. However, to say if a tumor is microsatellite stable or unstable, that could be done by immunohistochemistry, which is a kind of easy available test in the lab. Next slide. Right, so the point is that, let's go back. The main point is how we can treat with our classical methods the high-risk disease. These are the characteristics of the high risk, grade 3. more than 50% myometrial invasion, the one we defined at the beginning, lymphovascular space invasion. So in this group of patients, those who were treated in the PROTECT-3 study, which is the biggest study done as adjuvant treatment in high-risk endometrial cancer, there were the stages with more than one risk factor, stage 1, the stage 2 and 3. So the stage 2 with involvement of the cervix, and the stage 3 involving the parametrium, and then the non-endometrial subtype. Stage 3 including also the metastasis to the genital tract, so the metastasis to the ovary and so on. And the non-endometrial subtype, which means the serous clear cell. And the PROTECT-3 study was a randomized study over 600 patients comparing chemotherapy, systemic treatment, carboplatin paclitaxel, plus radiotherapy versus radiotherapy only, the combined external plus brachytherapy, to see whether the addition of chemotherapy could add something to radiotherapy. Next slide. And these were the characteristics of the patients. And as you can see that there was at the median follow-up of 72 6 months, there was a significant difference in the overall survival in the group of patients who received also chemotherapy versus the patients who received only radiotherapy. As well, there was a difference in the progression-free survival. These results were specific for this category, mainly in this category of patients for serous. So that's the comments is that this schedule should be discussed and recommended, especially for women with stage 3 or serous cancer. And this is important to remember. That was the status of art, the optimal treatment for those patients. Next slide. And these are the ESMO guidelines. I suppose you are aware of. Just to remind you that the standard of care chemotherapy is 6 courses of carboplatin and paclitaxel. And this is important for, I've seen one case which we'll discuss later. And also it's important that another option is the hormonal treatment, and that depends very much on the characteristics of the disease. And then I like to get the opinion of Jan on that, that if you have a rapidly growing disease, for example, if you, let's put in this case, a serous case with lung metastasis rapidly growing, you know, it's needed to do something quite quickly. So you can start with chemo because there's a diffuse disease. If you have a slowly growing disease, low grade, in patients who don't have symptoms, don't have a visceral involvement, you can try 3 months of hormonal treatment, because hormone should have an adequate period of time for testing, and then you can see if you can get some better control of the disease. However, this slide, which came from the recommendation in 2016 and updated in 2018, already said that it's needed to have biomarkers-driven clinical study. That was already discussed when we had the first classification with the 4 different genomic classes. However, there were not at that time so many opportunities or so many options as we have today. Let's go to the next one. And these are the recommendations. I've already mentioned, so you know already. And what is recommended today is the progestogens. there might be some contraindications to the use of progesterone, some previous vascular problems, or perhaps obesity, which is a very frequent concomitant pathology. And we know today that the incidence of endometrial cancer is increasing mostly because of the increase of the obesity in Western countries. So these are the recommendations. The alternative could be AI inhibitor, letrozole or arimidex. Next slide. Now, let's see how the molecular profile we discussed at the beginning has been applied to clinical practice and could be applied in clinical practice. So these molecular groups were identified by surrogate markers. So we were able to identify some particular characteristics of the cells histologically defined or defined by some molecular testing, which clearly divide the 4 different classes, and we try to adapt the treatment to the molecular characteristics of the disease. So this is the class 4, the serous one, and the p53 could be identified by immunohistochemistry, as well the mismatch repair, either the deficient or the stable, but in this particular pathway identified, the class 3 is non-specific molecular pathway. So something which is in between, is not serous, is not deficient, is clearly, it doesn't have clearly the pole mutation, for which we need a focused NGS. However, you remember that the percentage of tumors with the pole mutation is very low. And then the serous is around 20-25%, as well as this one, perhaps even less. So the big problem is this one, the non-specific molecular profile, the mismatch repair proficient population. Next slide. So the point is that once these 4 classes have been identified, they were included, or all the cases, 97% of the cases included in the PORTEC-3 study has the tumor tissues available, and there was the analysis of these 4 genomic classes applied to the patients entered in the PORTEC-3. And these are the percentage of expression of this mutation. So you can see 12%, p53 23%, and this is non-specific molecular profile. Then, if we look here, we can see that already, regardless the treatment which was done. So we don't know whether these patients received the combined approach, radio, chemo, or only the chemo. However, there's a clear difference in the survival curve according to the classes, which I think is already quite impressive, because it shows that there are clearly different entities within the name of endometrial cancer. So you can see that the pole E is almost 100%. So we can say these patients can stay as they are without any treatment. But then going down progressively, we have a lower overall survival for the non-specific molecular one, and then the mismatch repair deficient is here, and then here is the serous, which is very, very low. So the problem is here in the serous histology, and also in these 2. Pole, we can say it's already a good situation. Next one. And these classes were again applied to the PORTEC-3, what I showed you before. And as you can see, here we have all the patients who were treated. So there's a difference in the survival. However, if we go at the serous, you can see that this difference is even higher. So the point is that the green line is the combined approach, and the red one is only chemotherapy. And you can see that there's a substantial difference. So this analysis confirmed further the value of the combined approach, serous, chemo, and radiotherapy, in particular in the serous population. While here, okay, there's a difference, but it's not so relevant. So really is this particular molecular profile which affect the response to the treatment and to the prognosis of the patients. Next one. Now, then all the PORTEC-3 study were again analyzed according to the treatment, and from that there was the definition of the new endometrial guidelines, which have been already published by ESO and ESTRO. So the point is that we can say in the mismatch repair deficient, there's not such a difference between the two treatments. That means that we need something else. So that's not good only. We should look for another treatment. And the same from the non-specific molecular profile. So for these patients, we can even discuss if we need to add chemotherapy, because the survival is already good in some way. And here is the pole as well, while the problem again is here in this series. Let's go. So these are the new guidelines. So what is under discussion? The need of adding adjuvant treatment in the patients with the pole mutation. So that's important, and there was at the basis of the PORTEC-4 study. And the next one, this is the other one. So let's see, immunotherapy is starting to be discussed here. So in stage 1 to 4, in these patients, mismatch repair deficient, non-specific molecular profile, is there a role of immunotherapy? This is important. And also in patients with the p53 mutation, chemotherapy alone might be discussed already from the stage 1. So it's completely different change in which we were our prognostic factor. And also in the high risk, as we discussed, the combination is recommended. Next one. And this is the algorithm which has been suggested, and it's already used and will be tested in studies which will start soon. So the point is that we have all the patients, regardless histology, and then we can first see whether there's a pole mutation. Okay, we know that these patients are going well. Then if these patients are wild type, then we can see whether there's the mismatch repair deficiency with immunochemistry, the one we discussed already. And then if the patients are deficient, at this point, we can discuss the immunotherapy, and I'll show you some results. If the patients are proficient, then we can see which is the situation of the p53. If they are mutated, that's important to start chemotherapy at this point. If p53 is wild type, at this point, there are some particular treatments which are under discussion. But what I think is fascinating is that by using and putting clinical practice this molecular classification, you can get completely different treatments and results. Next slide. So that I think that for the sake of time, I'd like to focus on this summary I prepared this year, and there's a review of all the data which has been produced and the results which have been achieved with immunotherapy in endometrial cancer. Also, Ian mentioned the value of immunotherapy in endometrial cancer. So you can see that in macrosatellite unstable patients, because here we have macrosatellite instability, PD-L1 is not so relevant in endometrial cancer as it in cervical cancer. But here, with the dostarlimab, which is another checkpoint inhibitors, you can see some response in the stable, macrosatellite stable, even though the greater response in the unstable disease, as it is with the durvalumab and the other checkpoint inhibitor. So in these patients, we can say that immunotherapy is effective and is a good option. Next slide. These are the design of the Garnet study. Just to say that this is the study with the highest number of patients treated with the checkpoint inhibitors, because you can see there's the number of patients who were treated in the expansion part of the phase 1, more than 100 in both the groups, the deficient and proficient. So really proficient is the big problem in endometrial cancer. Next one. These are the characteristics of the patients who were treated. There's quite a substantial number of patients with stage 3 or 4 at the primary diagnosis. So poor prognostic, very unfavorable patients. Next one. And the dostarlimab was given in patients with recurrent disease. What is important to say is that there's a high percentage of patients with the response still ongoing, with the good follow-up. It's 16 months, but clearly we need longer follow-up and a good disease control rate. So Jan mentioned already for ovarian cancer, low response rate, but long duration of response. And this is one of the characteristics of immunotherapy. You don't expect to see a shrinkage of the tumor within 3 months. But the point is that patients who achieved a response are able to keep it long. And this is important for the progression-free survival time. Next one. Just to mention the toxicity of this treatment, because remember that treatment could be more toxic in endometrial cancer patients than in other gynecological malignancies because of the characteristics of the patients. They could be older, they have concomitant pathologies, which are usually the obesity, which might be also one of the related factors to the development of endometrial cancer. They could have hypertension. They could have other concomitant disease, which makes them more frail than other patients. And actually, if you look at the toxicity, you can see that the main toxicity is not really the hematological toxicity. The main toxicity is systemic toxicity, which means fatigue, which means diarrhea or lack of appetite. In general, it's well tolerated. That's a single agent, and the results are different when we use combination with immunotherapy. And you have some toxicity related to immunotherapy treatment, but mainly are fatigue and diarrhea. Next slide. Can I have the next slide? Mariam, could you hear me?
I can hear you, but I don't know whether
Right. Okay.
Okay.
No, you skipped some slides. That's we have 2 slides before that. No. Okay. Go on, please. Again, go on. Again. Next one. After that, okay. So the point is that these are the other good results which were achieved with the immunotherapy. And this is a combination study because you see that there's a pembrolizumab plus an anti-angiogenic compound, which is lenvatinib. This is the biggest study so far conducted, randomizing patients who received already a previous treatment. So they are patients with recurrent disease. They should have had a prior platinum-based combination. So recurrent or metastatic disease. And the patients were stratified according to the presence or not to the status of the mismatch repair, proficient versus deficient. The randomized chemotherapy was or doxorubicin or paclitaxel weekly, which are the standard options for a recurrent endometrial cancer. And the primary endpoint was the overall survival, so quite an ambitious endpoint, but that's an important one, the one we really valuable for the patients. Next slide. So these are the characteristics of the response, which I think are really interesting. In the all-comers, there was a difference between the lenvatinib and pembrolizumab versus physician choice chemotherapy. There was, however, also a difference, it is important, in the proficient populations. That means that this combination of an anti-angiogenics plus immunotherapy can have some effect in these very poor prognosis patients, or let's put in another way, in endometrial cancer patients with recurrent disease or metastatic disease after primary treatment with platinum. And these were the conclusions based on this data, which brought to the registration in USA for these combinations in the recurrent disease regardless the histology. It's not mentioned proficient, deficient, regardless the histology. Next slide. However, it's very important to remember that this is a toxic combination and should be managed, the patient should be managed carefully. So the point is that if you see the percentage of patients who developed grade 3 hypertension with the combination is 38%, which is very high, means uncontrolled hypertension, perhaps in obese patients, old patients, and so on. And also diarrhea grade 3 is more than 8 liquid stools per day, which is exhausting for the patient. Decreased appetite, weight decrease. So, you know, substantial toxicity. It's true that there's also toxicity in the physician choice treatment. However, it's definitely lower. It's higher the hematological toxicity, but I think the main problem are these 4. Next slide. So these are the recommendations provided by Vicky Macker, who did the study. So this is the point. We have 59% of patients and 50% of patients who required an interruption of the treatment, 31 of both lenvatinib and pembro, because sometimes it's difficult to understand which treatment was responsible of what. And there was a total of 14% of patients who had to stop the treatment, discontinue the treatment because of the severity of the toxicity. So the recommendations are to start with the dose of lenvatinib, which is recommended because the problem is lenvatinib, because that's clearly a toxicity related to anti-angiogenics, and then to reduce as medically necessary, which means that this patient should be seen weekly. And also, you know, we talked a lot of PARP inhibitors. For all this compound, it's necessary to titrate the dose to the characteristics and of the patients and of the bone marrow. So it's really important to see patients frequently at the beginning and then try to adapt the dose. And also, it's really important to have a supportive care of specialists who are informed, you know, the pneumologist because of the potential lung problems, the endocrinology because of the thyroid problems, the nutritionist, and so on. And also to inform the patients as well of the possibility of incurring in these side effects, and to know how to first deal with them, but then to contact the physicians and the team or the nurse as soon as possible, and then to have frequent weekly visit at the beginning of the treatment. So that's the last two slides to conclude my presentation. So the combination has been approved, the one I mentioned, anti-angiogenics with immunotherapy for advanced metastatic of recurrent disease. In the Europe, the dostarlimab, the one I show you, which is the greatest pool of patients, has been approved through a conditional authorization, which means that the study should be repeated in a larger patients populations as second-line treatment. And the discussion is related to deficient or satellite, well, deficient or unstable, not really on proficient yet, which regards the chemotherapy plus immunotherapy. There are studies ongoing. Some of them have been already completed and we'll have the results very soon. While also it's been under discussion on the combination with the PARP inhibitor, because we know that there are classes with the different tumor mutational burden, and we had the notion that perhaps PARP inhibitor could be effective in patients with the high tumor burden mutation as well as immunotherapy. Next one. So that's in general for endometrial cancer, obesity is really a risk factor. The other classical risk factor, grading, myometrial invasion, and lymphovascular space invasion are risk factor for the selection of the adjuvant treatment. The combined approach, chemoradiotherapy, is recommended in advanced serous histotype. And this new molecular classification with the 4 genomic classes had a prognostic value which is going under confirmation in prospective studies, which have started already within ENGOT group, which is the European cooperative groups. And there are already positive results with immunotherapy in patients with macrosatellite instability. And there are many prospective studies with immunotherapy to define exactly which is the best regimen for the patients with a suitable target. So thank you very much. I'm at the end of this presentation.
Thank you so much, dear professor, for your very informative presentation. And the floor is given to next speaker. She is Zoza Azimova. She works in Tashkent State Dental Institute in Oncology and Radiology Department, and her presentation is dedicated to the clinical case in the endometrial case. So you're welcome.
Oh, thank you very much. Good day, dear professors and colleagues. Thank you for your very cognitive presentations. I've already could get some answers to my questions. So, and it's a great honor for me to present a clinical case on the first international gynecology webinar organized by ESCO members. Well, everyone knows that in the last decade it has taken the first place among cancerous diseases of the female genitals, and the largest number of cases occur in post and perimenopausal women. Just a sec. So, well, my patient was a 52-year-old female, Korean female. In her past medical history, there are obesity, diabetes of second type, and varicose disease. The family history of cancer is unknown, and there is one and only pregnancy in gynecological anamnesis, which ended up and with miscarriage. Complaints were abdominal pain, bloody discharge from the vagina, and malaise. Examination per vaginum showed tumor in the right side from the uterus, 12 to 10 centimeters, and pelvis ultrasound revealed 11 to 8.1 centimeter cavity formation with multiple partitions to the right, and 32 to 30 millimeters cavity formation to the left of the uterus. There were no distant metastases, no free fluid in the peritoneal cavity according to the chest and abdomen CT. Well, CA-125 was high, 215 units per milliliter. The analysis of CA total HBCG LDH wasn't performed. Scraped biopsy from the uterine revealed papillary adenocarcinoma G2, and the preoperative diagnosis was endometrial cancer, T1 and OMO, right ovarian. Well, on MRI, the uterus is enlarged, and there is a tumor in the uterine cavity, spreading into the cervical cavity, filling and expanding its lumen. An inhomogeneous solid structured formation with ISA and hyperintensive signal characteristics with clear smooth contours. The transitional zone of the uterus isn't thickened. The endometrium and endocervix are compressed, not clearly differentiated. The perimetry is without any features. The cervix is of the usual shape with sclerotic changes. Well, what about the left ovary? In its structure, multiple cysts of the Nabatean glands with a homogeneous liquid content. Irregular volumetric formation adjacent to the body of the uterus in the lower medial parts of the right ovarian fossa in homogeneously cystic solid structure with clear and rough contours. Also, in the upper outer parts of the right ovarian fossa, cystic area with the liquid content with clear and rough contours is visualized in an elongated, convoluted shape. The left ovary is in the structure has sclerotic changes with clear and rough contours. Moderate effusion is determined in the small pelvis, in the retroperitoneal space along the iliac vessels, and in the inguinal regions. Single lymph nodes are determined. What about the treatment? During the revision of the abdominal cavity, free ascites fluid is not detected in the abdomen and small pelvis. There are no signs of tumor dissemination in the parietal and visceral peritoneum. Lateral parietal lymph nodes are not enlarged. As a result, we didn't perform lymph node dissection. Frozen section on the right ovarian tumor was performed, and pathological report determined papillary adenocarcinoma G2. The patient underwent radical hysterectomy, BCL, and amendectomy. Well, this is the frozen section of the right ovary, papillary adenocarcinoma. When the body of the uterus is cut, the tumor that fills the uterine cavity is identified with signs of central decay coming out of the endometrial layer of the uterine tube. The tumor extended to the lower part of the uterine body, growing into the myometrial layer about half of centimeter. The cervix and cervical canal are unchanged. A cystic tumor measuring 10 to 13 centimeter from the right ovary, blue in color, with a relatively thick capsule. containing both fluid and tissue. The size of the left ovary is 3 to 2.5 centimeters. The surface is covered with a bluish capsule. The cyst is altered. A large momentum without visual changes. You can see on this photo the endometrial tumor. Okay, and we can see in pathology conclusion papillary endometrial cancer with spreading to the right fallopian tube and right ovary. Postoperative diagnosis was determined such as endometrial cancer PT3A, NO, MO, 3A. Well, recommendations were adjuvant chemotherapy, 6 cycles of adjuvant therapy with carboplatin and paclitaxel by TPC. And radiotherapy, it was a distant radiotherapy 44 grays and to pelvis, and brachytherapy 30 grays also to pelvis. So, as I've said before, thank you, Professor Sessa. Your lecture was so cognitive. I've already could get several answers to my questions. However, although I'm gonna just read them out. What would be the best option for diagnostic checkup before surgery? MRI contrast or PET-CT? How can be distinguished the region of primary cancer? It can be papillary endometrial cancer with spreading to ovary, or papillary ovarian cancer spreading to endometrium, or multiple primary cancer. Does it have any practical significance? And is IHC recommended for hormone therapy prescribing? What is the role of HIPEC in the case? And what is the role of immunotherapy in endometrial cancer? Thank you. Oh, Professor, I can hear you.
Yeah, so sorry, I can see your slide in the full screen. I see only in one side. I printed the case, but anyway, I can read the question. I see the faces of the audience, but not the full screen. Anyway, so the first question is that what would be the best option for diagnostic checkup? It's something we discuss with the surgeon as well, because that's something that in endometrial cancer allows us to define the extent of surgery. So usually they like to have an MRI to define the parametrium. This is mostly in cervical cancer, but also in endometrial cancer would be useful. I have, because the point is that there was already some suspicious that there was something in the right ovary. Also, there was a cavity formation with multiple partitions and so on. So there was a continuity. So it would have been important to define also this part. You perform a radical hysterectomy. I don't know whether this means radical with the excision of the parametrium, but usually there are no indications for radical hysterectomy in endometrial cancer. That's for cervical cancer. Well, I think it was good to have the omentectomy, which is usually is not done in endometrial cancer, but because of these particular characteristics of the left ovarian enlargement, let's put it this way. Then the second one, how to distinguish the origin of primary cancer. It could be papillary. Papillary, do you mean serous? What do you mean by papillary?
Papillary endometrial cancer.
Papillary, Ian, what do you think? Papillary endometrial cancer, is that endometrioid or is serous?
Yeah, I think it's serous. Yes.
It's serous,
yes.
yeah. It's serous, so the worst one we've seen.
Yeah.
So that was the point. And in this way, there are immunochemical tests to define whether it's a ovarian or endometrial origin. In this particular case, I think that overall it's important that it was defined that the origin was from the endometrium, because it brought to the decision to add radiotherapy, which is important in the treatment of the serous histotype, as we defined in the molecular classification. So I think at this point, also the other point is that you can perform a P53 analysis, which is always, almost always mutated in ovarian cancer. But if you have also in the uterine cells the P53 mutation, that's clearly it, and it's online with the serous histotype. So I think it would be useful to assess this particular treatment. Anyway, there's no indication for immunotherapy in this case, according to the molecular classification. So you took the right decision, because you gave chemotherapy and then you had the radiotherapy. So the point is that when you use the combined approach, it's really important to try to put together the two modalities of treatment, because you should avoid the toxicity, because the point is that in these patients are both important, the chemotherapy and the radiotherapy. And what was done in the Portex study was to have a kind of a compromise, because there was a concomitant treatment during the radiotherapy, which was weekly cisplatin, or you can give also cisplatin every 3 weeks as a radiosensitizer. And then there were 4 cycles of chemotherapy, because 6 would be too many. And the patients would, if you start with radiotherapy, the patient cannot stand the 6 courses. If you start with 6 courses of chemo, the patient is not able to finish on time the radiotherapy. So it could bring to a compromise of the 2 treatments, which is not good. So try to adapt as well to the characteristics of the patients and to the tolerability.
Christiana,
yeah.
Can I ask you, the general difficulty between assessing whether you're dealing primary ovarian cancer with metastasis to the uterus or vice versa, what would you think would be the best way to discriminate these 2 situations? Because it's not always easy.
Yeah, I think the point is that I don't know in this case, but perhaps one point is that in case of ovarian cancer, it starts from the fibria of the fallopian tube.
Yes.
And then perhaps in this case there was also an involvement of the fallopian tube, which would make things more difficult. But this could be, I think, in my opinion, something good, because if you have a tumor growing in the fibria without being involved by the uterus, that's clearly an ovarian cancer, because that's an important point. And then we have the different tests, the PAX1 and so on. Pathologists know very well. The other point, but also in this case, you didn't have, or you had the CA125.
Yes, it was a little bit elevated, yes.
Yeah, it was elevated, but the point, well, the tumor was growing outside the capsule, so it could be also reason for the P53 increase. The other point is that you can see whether you have hormone receptors, but in this case of serous, the hormone receptors are usually negative. So that's not also a good point. And then it was the point of is a grade 2 differentiation. Well, that's not so relevant. I think that it was important to define the origin, because you added the radiotherapy. If it had been only ovarian cancer, you wouldn't have added chemotherapy, and there was the crucial point. Yeah, I don't know, Jan, if you want to add something on that.
No, I think that the fact that it was ultimately a stage 3A is already, you know, you're dealing with an advanced disease setting. And the point is that chemotherapy after surgery would be standard of care for ovarian cancer, and only that the decision was made to give radiotherapy means that they have sufficient arguments to think that the primary tumor was from the endometrium. And the point is that the anamnesis is not so particular, because vaginal bleeding can also occur with primary tumors in the ovary. So it's not that they must have had other arguments why they considered this a primary tumor of the endometrium. And I'm still not completely certain what exactly the arguments were, how they came to that decision. Maybe that Dr. what was her name again? Dr.
Pathologist.
No, Azimova. Perhaps she could summarize what exactly were the reasons why they decided it was a primary endometrial carcinoma.
Could you just repeat the question, because there is a...
Yeah, the question was, you evidently came to the conclusion that this was primary disease from the uterus and not from the ovary. Can you summarize what was ultimately the final reason that you decided that it was primarily coming from the uterus?
Well, there was a conclusion of pathology.
And was that based on marker assessment?
No, histological. On histology.
From the macroscopic characteristics of the disease, so to see how was the growth and inside the uterus and so on, something like that.
Yeah, I suppose so. So you have no more arguments than just the histology, and there was not in the pathology report a very clear description what the difference was between considering it as primary uterus versus primary ovary.
Well, there are a little bit differences in the system of European standards and Uzbekistan standards. That's why I'm a surgeon and I'm doing operations. And there is another doctor, oncologist, who is doing chemotherapy, radiotherapy, and the morphological examinations, like revision of macropreparatus and histological conclusion. So that's not my, I can say, that's not my profile.
That's why you have multidisciplinary.
Yes, that's why I have no idea how to answer to your questions.
Yeah, no, I understand.
Oh. Yeah.
Well, I think, another point that I want to make about the immunotherapy, I think that about 1/3 of the endometrial carcinomas have MMRD or MSI, and I think that's a very important selection criterion, because the treatment with the checkpoint inhibitors in general is quite favorable in terms of toxicity, and we're dealing now with recurrent metastatic disease. So I think that it is certainly worthwhile to test, to make that test in these circumstances. Yeah. And I know that Professor Sessa was mentioning already that some patients are better off with hormonal therapy and some patients might be better off with other therapies. But I think that very lately, this discrimination of MSI and MMRD is important in selecting those patients who might benefit from checkpoint inhibitors.
Yeah.
And I think in terms of toxicity, that checkpoint inhibitors are attractive, but you have to realize that elderly people, and many of the endometrial carcinomas are occurring in elderly people, they have a somewhat different toxicity profile with checkpoint inhibitors than the younger patients. So they have more skin toxicity and somewhat less endocrine disturbances, like in the younger patients. I don't know, Christiana, whether you have experience with that also, because I suppose that you are seeing a lot of elderly people there also.
Yeah. No, immunotherapy generally well tolerated. The point is that you should follow closely the patients at the beginning, because that's important. How much is the tolerance? How good is the tolerance? Another important point is that the combination is very good with anti-angiogenic and so on, and it's toxic. And we don't have a comparison study showing clearly that the combination is better than the single agent. And this study won't be done anyway, because already immunotherapy are in the market and so on. It wouldn't be feasible to do it. So far there's no recommendation to start with a combination with anti-angiogenics and immunotherapy. So the indication is for single agent immunotherapy, and which could be adapted. And what is really important is that everybody should be informed, everybody in the team of people caring for patients, that this patient is receiving immunotherapy, because when the patients call and they have problems, it's important to find somebody who can ask properly and know what has been given and which could be the potential problems in terms of skin toxicity, diarrhea, fatigue, and so on. So it's needed a small structure, not so much, but just to be organized.
Yeah, but I must admit that if I have seen your data on lymphatinib with Pembro, that is not a piece of cake. I mean, that's for older people, not an easy treatment.
No, exactly. So the toxicity, if you compare the same combination in different tumor types, the greatest toxicity is in endometrial cancer patients because of the concomitant disease, and this is the point.
So how would you balance then the indication for hormonal therapy for recurrent metastatic disease versus the immunotherapy checkpoint inhibitor?
Well, I think the point is that if there's a macrosatellite instability, and we'll start first with immunotherapy, because you have the possibility to achieve a longer duration of response. If you don't get anything substantial after an adequate period of time, because you cannot expect that you have a quick response to the treatment. Let's say after 6 months, you can decide to switch to hormonal treatment.
And do we have a lot of data on hormonal therapy after checkpoint inhibitors?
I suppose that there are, because many patients are receiving now immunotherapy in endometrial cancer, but I'm not aware of. I think this is, for example, a nice study to be done, but certainly patients who are treated in the in study, there will have data on hormonal treatment after immunotherapy, because these patients with immunotherapy, they need a very long follow-up to see how long is the response. So I suppose that there will be data also on the subsequent treatment.
Certainly. Very good.
And then there's no indication to use IPEC in this particular.
I agree with that.
Yeah. Do you agree, Jan?
I agree with that, yes.
Okay. Very good. So thank you so much. It's an
Thank you so much. We have very good questions and answers from our professors, but we are a little bit late. Then we will go through next clinical case, and then we will have some questions to you from the floor. Next participant, my colleague, Lika Katselashvili. Lika, please.
Warm greetings to everyone. Do you see my shared document or no? Do you see? Chance Mariam, taşıyabilir.
Here is a little bit problem. Alicia, can you help us, please? Or I will help you, Lika. No worries.
I think there is some problem with her internet. I mean, Lika do not have good internet now.
Yes,
Do you
Lika.
see?
Yes,
I shared.
I see some black spots on the slide.
Lika, you can stop your sharing your screen and I will help you.
I'm sharing. Do you see?
No, it seems that you are some technical problems and I will help you. I will share your slides and Lika, please stop sharing your screen and I will help you.
Okay. Okay, I will stop. Okay. I stopped already.
Yes. I need only 1 minute.
Yeah.
Oh,
That's
yeah.
better. Yeah.
Good.
Okay. I'm very sorry for the technical issues.
Well, problem solved.
It is great. Okay, thank you to all. It is a great honor for me to be one of among so okay, thank you. Among you, and I will start my case. Next, okay. My first case is about uterine carcinosarcoma. My patient is 56 years old, female. She does not have any comorbidity, no family history of cancer. She was diagnosed in abroad. Diagnosed was endometrial carcinosarcoma, and there was advice to do surgery. Then the patient admitted at our clinic, and the surgical treatment was performed here in our clinic. Surgery was radical hysterectomy, omentectomy, lymph node dissection, and biopsies from bowel and peritoneum. After surgery, next please. Pathology report showed high-grade endometrial carcinosarcoma, grade 3, PT3B. There was dissected 75 lymph nodes, and from them 55 was metastasis. As surgeon told us, there was macroscopic peritoneal metastasis here. From them, several was biopsed, and there was endometrial carcinosarcoma by pathology report. But after surgery, radiological examination was not showed there was no visible metastasis here. Next, please. Next, please. Okay. I have a quick question about false adjuvant treatment, maybe by docetaxel or gemcitabine, or maybe monotherapy by doxorubicin, or can we treat as metastatic disease in case we know that there is macroscopical carcinomatosis rest in the abdomen? Is here any role or a HER2 or MCI examination, or do you advise another option of treatment?
Perhaps we can start discussing this first case, which is a carcinosarcoma of the uterus, because then there's a case of ovarian cancer. So
yes.
That's I'll give you my answer, and then Jan, perhaps you can give yours. So that's a carcinosarcoma. There's a mesenchymal component, but there's also epithelial component. And this is a high grade with intraperitoneal spread. So I think there's clearly an indication for, it's not actually an adjuvant treatment, that's a palliative treatment, because there's still residual disease, if I have well understood, because there's still the peritoneal carcinomatosis. But that said, no measurable lesion after surgery at the radiology, but peritoneal carcinomatosis, which means that the peritoneal carcinomatosis was still inside, is it?
Yes, sure, yes.
Okay, so that's an indication for some adjuvant or better palliative treatment. The recommendation for carcinosarcoma is carboplatin paclitaxel. So that's the treatment you mentioned are the regimen used for leiomyosarcoma of the uterus, or the anthracycline, or the combination of docetaxel and gemcitabine. So in this case, carboplatin and paclitaxel 6 courses. There's no indication to add radiotherapy in this case, because that's the characteristics, histological characteristics. There's no indication for macrosatellite instability as well, because of the characteristics of the disease. And also the data in HER2, there are some data in serous histotype, but they are not so exciting. And anyway, there's not an indication to add, in my opinion, to a trastuzumab in case of positivity. So that's something related to serous endometrial cancer. So it's a completely different pathological situations. And other option of treatment, I think that we would have done what you did. I think it was surprised, if I have well understood, that the histology which was found, the high-grade carcinosarcoma, because that's something you got from the surgery. You didn't have any histology before starting before going to surgery. Is it correct?
Yes, it's correct. The diagnosis was done in different country, not in Georgia, and the patient admitted with the diagnosis to the surgeon.
Did you have a histological biopsy of the uterus?
They did in a different country, and they know that there was a carcinosarcoma in the endometrium.
So
the endometrium.
The patient arrived with already a diagnosis of carcinosarcoma.
Yes.
Okay. But it was stage 4. So you decided to go in to see from where it originated, or try to decrease the bulky disease. So did you discuss with because there's no mention of the radiological images?
Yes, in the beginning, this stage was 3. There was no any evidence of carcinomatosis or so huge numbers of lymph nodes. It was a logistical problem between the radiological examination and between the surgery. There was about 6 or 8 weeks. So maybe between this time, the disease was progressed. Because in the initial radiological examination, there was not mentioned so huge numbers of lymph nodes or carcinomas.
Yeah, that's quite impressive. So impressive for 2 things. That it was really a good lymphadenectomy, because there were 75 lymph nodes excised. So congratulations. And the other point is that 55 were positive. Which is clearly related to the aggressiveness of the disease. So even more was indicated to start with chemotherapy.
Yes. Thank you very much.
Yeah, and you want to add something?
No, I fully agree with this. I just wondered the reason that you asked the question, adjuvant treatment, docetaxel, gemcitabine, or doxorubicin. Does that mean that you have started to treat the patients with that regimen, or what?
No, this patient was consulted by another clinical oncologist in abroad where the diagnosis was done, and they advised the regimen docetaxel gemcitabine, and I'm very happy that my opinion was paclicarbo, and your opinion is the same. So my suspicious was I right or not?
Yes.
Yes. So I'm very happy because my opinion and yours are the same.
Very good.
Thank you.
So, and what happened with the patient?
Now we are starting paclicarbo.
Oh, you're starting.
But they are waiting your answer too, because I prescribed paclicarbo, and another option was GEMC and DOTE. So your opinion was last.
Okay.
Very good.
Yeah, and so the remark that Professor Tessa had about the multiple lymph nodes, I think that is also important information, because if it would have been only lesions in the peritoneum, then I think that in my institution, the surgeons would have asked me whether I would have thought that this might have been interesting for HIPEC, for instance.
No.
No. And I would say always to them, if you want to study HIPEC, you have to write a protocol which clearly, describes what kind of patients should be in the protocol. And on an individual basis, to treat patients with HIPEC is wrong. So if you want to silence the people in your institute about this sort of experimental treatment, then first they have to write a protocol which is screened by everyone. And then you can select the patients on the basis of a running protocol. Never treat a patient outside anything than a protocol. I think that would be very important.
Yeah, fully agree.
You follow the guidelines, or you ask the patient to participate in the protocol, but don't start treating anyone outside protocols or guidelines.
Yeah.
Thank you. My next quick case is about ovarian cancer. This patient is 65 years old, female, no family history of cancer, but comorbidity pulmonary emboli was in March after the surgery, and she has also arterial hypertension grade 2. This diagnosis was in March, and hysterectomy, bilateral oophorectomy, a mantectomy, peritoneumectomy, and tumor resection from the intestinal was done in March, and pathology showed ovarian serous carcinoma, PT3C, grade 3. There was lymphovascular invasion, and from biopsies of the peritoneum, there was pathological changes also. After the surgery, this patient had pulmonary emboli, so she treated and was hospitalized afterward. Next, please. Next slide. Okay, thank you. After her recovery, radiological examination showed new metastases in the liver. This metastasis was sized about 25 millimeters. So we decided to do chemotherapy with paclitaxel and carboplatin without bevacizumab because of the pulmonary emboli and the risk of another thrombosis. So we did 6 cycles of chemotherapy. In the beginning, CA 125 was 52, but last examination showed only 11. But after 6 cycles of the chemotherapy, liver lesion decreased in size about 65%. There is very good response, but there is a new lymph node, paraortal, only a single lymph node, sized 14 millimeters. So our MDT was last week. We could not decide any treatment. How can we treat this patient? And I have several questions. Next slide. How do you consider as platinum-refractory disease due to this new lymph node? And continue as platinum-refractory disease, or do you see any role of hormonal therapy because there is good response in the liver metastasis and there is decreased and normal ranges of oncomarker, or maybe close follow-up or another option do you have? Thank you.
Yeah, I think these are situations that we sometimes are confronted with. It's not always so easy. I understand that all the other lesions disappeared. Is that correct?
Yes, only new lesion, new paraortal lymph node.
Yeah. So the liver metastasis disappeared completely.
No, there is 8 millimeters rest in the liver.
So it's not completely gone.
No, partial responses. 65% decreased in size. This liver mets was single metastasis in the liver. Only this was after the surgery, but now there is another one, another lymph node.
Oh, another, yeah, but there is not an increase in the liver also.
No increase, decreased.
Okay.
Decreased. Good response. Yeah.
Yeah, good response. So, well, you have. I think here you should discuss whether you just follow up or are using hormonal therapy, as you mentioned. I think that I would most probably, because also the CA125 normalized, I think I would suggest to repeat the CT scan after 3 months and then decide what to do. The patient has no symptoms, I suppose.
No, she feels very good.
She feels very good. And is she very eager about receiving any treatment, or is she someone that you can discuss the options very well with?
No, what we decide, she will do everything.
She would do everything. Yeah.
Yes.
So if you would say we think it's wise to repeat the CT scan after 3 months and then decide what to do, she would understand that.
Yes, we're pretty good. My understanding.
Yeah, I think I would be in favor of that. The alternative of hormonal therapy, of course, you can do. We discussed that earlier. That is an option, but it's not necessary to do so. So this is what I would suggest, especially if the patient has no symptoms. I think because continuing with the same treatment and giving her more toxicity of that, I think it doesn't seem to me very sensible to do. Christiana, what do you think?
Well, I think the point is that actually there was not a good response to the treatment overall, because there was a new lymph node, the metastasis in the liver disappeared, is a mixed response. So I suppose in 3 months there will be a progression of the disease. However, the patient is asymptomatic. She's not really she doesn't want to receive another treatment immediately. She's aware of the situation. I agree with your opinion to wait for 3 months and repeat the same radiological investigations which was done at the end of the treatment. Yes. The other option could be, however, I think it's a refractory disease, because also the stage 4 at the presentation with liver metastasis, high grade paraortal lymph nodes. I mean, that's very unfavorable presentation. However, there's a mixed response.
Yes, I agree with that. But the only thing is that I like to have repeated information about a consistent increase in the lesion.
Yeah.
Now you have only one observation, and I think it would be better to have two in order to be sure that it is a rapidly progressive disease.
Exactly.
Yeah.
So the point is that I don't see that there's a role for hormonal therapy now. In
Yeah.
case of progressive disease, I suggest weekly paclitaxel with BEV.
No, I wouldn't give BEV because the patient is prone for thrombosis and for
yes,
hypertension.
well, but okay, that was but it was before surgery or after surgery?
After surgery.
After surgery. The point is that there was a response, but he's still on the anti-aggregants.
Yes, she's taking.
She's still receiving anti-aggregants. Okay. I think BEV would be a risk for this patient who has already not such a favorable prognosis.
No.
So I think weekly paclitaxel because in some way, she responded to paclitaxel. And perhaps an intensification could be useful, or to use it as anti-angiogenics.
And I must say, I like also pegylated liposomal doxorubicin, which is very well tolerated and it has the advantage that you don't have to see her weekly and can give it every 4 or 5 weeks. That is also, in terms of comfort of life, I think is interesting for the patient.
Yeah.
Thank you very much.
Okay.
Thank you, Likat. Thank you, Professor. We have several questions from the floor, but we are a little bit
I should leave at 1:30. Sorry for that. But
yes, we are late, and maybe we will discuss them later.
No, but let's see the questions.
Thank you so much. We often talk with pathologists about the molecular groups, and our question is, when do we need determination of molecular groups at diagnosis, or when the patient has recurrent disease or metastatic? When do we need it?
You mean in endometrial cancer?
Yes.
Well, at the diagnosis, because at the time of recurrent disease, well, you can go back to what you have in the archives, but the point is that you don't know really what you have at the recurrence of the disease. You have some places where the biopsies could be done and which could be the characteristics. I think if you do it at the beginning, you have already an idea of the potential prognosis of these patients, which and also you can decide mostly for the stage 1 if you have to add something to the initial treatment or not. So I think it's important to identify the high risk patients and to establish the treatment and follow up. That I think would be important. Jan, do you agree with that?
Yeah, absolutely. I agree with that. And I would add that for ovarian cancer, I think it's important to detect whether the patient is BRCA mutated or not, and do that at the beginning.
Yeah, fully agree, because you have a clear indication for first-line treatment.
Yes.
Yeah.
Thank you so much. And there was some question, one question from pathologist. Katie, please.
Yeah, in our country, mutation test is this one. Are too expensive and most of the population can't afford it.
There was a questions about the surrogate markers. And
yes, I can.
Katie, please.
Can you hear me? Yeah.
Yes.
Thanks a lot for very interesting talk. My first question is regarding to MMR and MSI testing. You mentioned that immunohistochemistry is a good tool for that. If you could choose between immunohistochemistry and MSI testing based on microsatellite testing themselves, which one would you choose? Would you go for MSI testing? I mean, by microsatellite instability identification.
Yeah, with the immunohistochemistry.
Still, okay.
Yeah.
And if there were MLH1 hypermethylation, not the mutation, would it still be considered MSI high, right?
Well, yes, in some way, yes, because it affects the possibility of repair.
So it's not related directly to Lynch syndrome. It's just MSI due to any.
I mean, well, that's endometrial cancer. That's important.
Yeah.
The family history. Of course, you should exclude that there's also a Lynch syndrome, but the characteristics of the endometrial cancer within a Lynch syndrome usually are a bit different one from what you can see from the primary tumor. Of course, as always, the family history is relevant because if you say that there's a Lynch syndrome, you need also to complete the staging with the colonoscopy and so on.
Yeah, thank you. And one more question about P53. Is the immunohistochemistry also a good surrogate here, or?
Yeah. We are doing that. We don't do other. It's something which is feasible, and what is important is it's something which is available. So even though it's not the optimal test, but if you have something available together with histology, you can already for endometrial cancer draw a conclusion on the treatment.
Thank you very much.
Do you agree, Jan, with that?
Yeah, no, I think that is very practical. I think that that's very sensible to do. Don't start with anything that you don't have experience with, and use the thing that you're accustomed to do. I think that that's the best way. And that also holds for PD-L1 expression and that sort of thing. That's also important that you use an assay that is quite familiar to you.
Yeah. And I mean, PD-L1 is not relevant for endometrial cancer.
No, but no.
Yeah, so that's forget it. Yeah.
But it is relevant for several other tumor types. So, for instance, I'm thinking about the other item that I'm very interested in head and neck cancer. It's very important to do it, and so
and the cervical cancer.
Cervical cancer is the same thing. You know, that's important to know the PD-L1 expression. I saw there is also a question about HIPEC, and of course,
it's yours, Jan. You are the expert.
Could you please clarify in which cases you suggest HIPEC? Well, I think if you look at the NCCN guidelines, there is only one group of patients that they advise that it could be considered, not that it is something that they advise, but they say they could consider it, and that's in patients at the time of interval debulking surgery. And that is based on a randomized trial that was performed in the Netherlands and published recently in the New England Journal, showing survival benefit. And the survival benefit is about the same as what you can obtain with intraperitoneal chemotherapy. It's just simpler because it's only one administration and one treatment during surgery. So I think that is something that is of interest if you have experience with it. That's number one. And that's the only indication at this moment that is being supported by NCCN. And as I mentioned to you, the use of HIPEC after surgery as primary treatment is not standard, is something that is under investigation in a randomized trial at this moment worldwide.
Our webinar was too interesting, and that's why we are late. Thank you so much for all participants. Professors, you did a great job for us. It was too impressive, and it was too important for our practice, for our knowledge, for our experience. Thank you so much. It was first time, and I am sure we will continue working together. And a lot of thanks to my partner, Alicia, to my colleagues, and to my dearest professors, Professor Alberto Costa, and Vermorken professor, and Professor Cristiana Sessa. A lot of thanks for your greatest recommendations and time shared with us. Thank you so much.
Can I tell you something, Mariam, and to
Yes,
all
of
the
course.
people? You did really a good job, because usually Jan, for other people, Jan wouldn't have accepted to do this kind of activity, because he said that He won't do any longer some. Is it correct, Jan?
Absolutely correct.
Exactly.
And
So
it is only that Mariam asked me to do it, that I am doing it, because I decided to stop doing the ESO courses. And so it was especially for you, Mariam, that I did this.
Yeah. So it was
what I have to say, it was a great pleasure to see my good friend Christiana again.
So I want to thank you for two things. For organizing the meeting and for this lively discussion. I think nobody realized that we have passed 3 hours and a half discussing cases. That's, went away very quickly.
So sorry.
But also because I had the opportunity to say again my big friend Jan. So it was, let's say, multi-causes pleasures. Let's put it this way. Yeah.
Thank you so much.
So
thank you.
Take care. Have a nice day.
Congratulations. Thank you, Jan.
Bye.
Hope to see you soon again.
Yes, very good.
Bye-bye.
Bye to all.
Thank you so much.
Mariam.
Have a great evening. Goodbye.
Bye.
Well done. Bye-bye.
Bye-bye, dear professor. Thank you. Thank you for your help and support.